Good morning, everyone. Thanks so much for joining us this morning. It is a very cold but sunny morning here at Oshawa. This is where the regional cancer team has set up for today to bring you this really great morning of some interesting information and just extra updated information that you can share with your clients, but you can also use for yourself and share with those that you love around you. I am Sarah Ashton. I am the regional manager for the Central East Regional Cancer Program. I just want to say a few things this morning. First of all, a big thank you for joining us. I hope you're warm. I hope you're comfortable on this cold morning. We're really excited for the information that's going to be shared with you today. I want to say a quick and very important thank you to the regional team, the Central East Regional Cancer Screening and Prevention team, for their hard work to bring this great event to you. So specifically, I'd like to call out Glenda Russell, Namisha Joseph, and Caitlin Loudon, who are all in the office bright and early this morning to bring this to you today. So very quickly, I've already introduced myself. I've said our thank you. I do have a few housekeeping items, but first I would like to start us off with a land acknowledgement. So I respectfully acknowledge that I have grown up and continue to live in Port Perry, Ontario, located on Treaty 20 of the Mississauga Territory, part of the Williams Treaty First Nations. These lands are home to the Mississaugas of Scugog Island, Alderville, Curve Lake, Hiawatha, Georgina Island, Beausoleil, and Rama First Nations. Indigenous peoples have cared for these lands for generations, passing down teachings that guide stewardship in connection to the land, water, and all living things. I express my deep gratitude for their care, both past and present. As a Scottish and English descendant with family roots in Durham region since the 1860s, I acknowledge the privilege I have experienced, including clean water, fresh food, quality education, accessible health care, and the safety of growing up with my family. Opportunities that many Indigenous peoples in my community and across Canada have been denied as a result of treaty violations. Some of my earliest memories are of times with my family in nature. My love for nature is influenced by my parents, especially my father. Growing up, he shared stories and teachings he learned from Indigenous peoples while working in forestry north of Thunder Bay. These lessons included survival skills, hunting practices, the wisdom of animals, and the importance of caring for the land and water. Alongside these teachings, he's also shared stories of the devastating impacts of colonization and broken treaties. I'm grateful for both the beauty and the painful truths within these stories, which help me recognize the depth of Indigenous knowledge and the profound losses suffered by Indigenous communities. Today, I recognize that my understanding of Canada's true history remains incomplete, and I'm committed to deepening my knowledge, acknowledging the benefits I've received at the expense of broken treaties and promises, and taking action in solidarity. I'm grateful to the elders and Indigenous knowledge keepers who continue to share their experiences, allowing myself and others to learn, reflect, and work towards meaningful reconciliation. So a few housekeeping items. We do have time at the end of each of the presentations for questions. There will be opportunity at the end of the day to ask questions of the Regional Cancer Program. However, the speakers will not be available at the end of the event. So if you have any questions, please use the Q&A function at the top of your screen to enter a question, and we will moderate those questions and get answers for you at the end of the presentation. If something comes up that you want to ask and the speaker has left the event, we will follow up with them to get an answer for you, and we'll follow up afterwards through email. And we will also acknowledge that the certificates will be given or handed out within a couple of weeks of the event. We need a bit of time to prepare those. So just please reach out within a couple of weeks if you've not received, but you should have those within a week or two. So So now I'd like to introduce you to Glenda Russell. Glenda has been the MRT lead for OBSP in the Central East region for 14 years. She has over 30 years experience of specializing as a mammography technologist, both internationally and here in Canada. Glenda is passionate about coaching other technologists to deliver high quality imaging and care for their clients. She prides herself on her ability to guide clients through the screening process with empathy and clear communication to help alleviate anxiety during what can be an emotional experience. Today, Glenda will be our MC for the event, and she will be introducing our speakers and directing your questions throughout the day. So thanks so much, Glenda, and I'll hand it over to you.
Thanks, Sarah. Good morning, and thank you all for joining us on this early, cold Saturday morning. Before I get started introducing our speakers, there's a few items that, like Sarah, I just wanted to reiterate. This event is being recorded for accountability for our licensed sponsors from CAMRT. All technologists that stay on this event for its duration will receive 4.5 Category A credits. Radiologists, physicians, nurse practitioners will also receive a certificate of attendance. Again, the survey will be posted at the end of the slides, and kindly take the time to fill this in as your responses truly guide us to bring you further events. As Sarah said, the certificates will not be automatically generated, and they will be emailed to you within 2 weeks of this event. We hope you enjoy our lineup of these great speakers today, and feel free to enter any questions in the Q&A function.
Thanks so much, Glenda. To get us started, we do have a message from our breast imaging lead, Dr. Rola Shaheen. She is not able to join us today. She's at a conference international in Africa. So she did send her well wishes in a pre-recorded message. So we will share that with you now.
Shaheen. I'm the Regional Cancer and Breast Imaging Lead for the Central East region. I'm so happy to welcome you all to the Breast Health from a Screening Perspective educational event today. Just to cover the Central East region, it includes Haliburton, Kawartha Lakes, Peterborough, Trent Hills, Northumberland, and Durham region. So the OBSP achievements in the Central East are the following. So recently, we had a lot of quality improvement projects, and with the goal is two things in mind. OBSP participation rates need to be improved, and to improve on our wait times. So one of the things that we're very proud about is the public wait time dashboard. We developed a public-facing wait time dashboard for all breast screening sites, which enabled our patients and providers to choose the shortest wait time location, the facility that can provide a screening mammogram, for example, from an interactive. And this was really a big hit because it was adopted provincially following a regional success. And we noted an improvement in overall wait times following the implementation of this dashboard. Also, we work on our social media, reaching patients where they are. We developed several social media campaigns to increase awareness and uptake of the cancer screening. We used marketing tools to reach under-screened populations, and also we partnered with Ontario Health teams and local hospitals to align the messaging across the channels so that the patients will have the same message wherever they go. Additionally, another very important tool from workflow point of view, the digital image transfer project. We implemented a digital image transfer system to replace the manual couriering of CDs between sites, because those can be lost, correct? And it takes time to get them. So this enabled enhancing safety at, so basically no lost data, also instant access, so the timing would be perfect in terms of like receiving it on time, efficiency, and which reduced delays in assessment. Nearly about 1,000 image files transferred since we went live in July 2025. Additionally, the online appointment booking. Collaboration with OBSP sites across the region to increase access to the online appointment booking. The goal is to go 100% adoption. Currently, we have 82% implemented, and patients can book their the appointments at their convenience, eliminating waiting time on hold, language barriers, and phone tag. So it's fully integrated with site-specific workflows. Our outcomes, our participation rates, we've seen steady participation rates for the 50 to 74, despite increased number of people eligible for screening in our region. So yes, we have lots of work ahead of us to improve this, but that's across the board. Also, we increased the participation for the 40 to 49 once the door was open and OBSP implemented to have the participation of this group of women. The wait times, we have seen an improved 5-week indicator wait time to diagnosis without tissue biopsy and now surpassing the provincial target. Additionally, we improved the 7-week indicator, which is the wait time to diagnosis with tissue biopsy, approaching the provincial target. And on this positive note, I would like to welcome you all and have you enjoy the session, all the sessions today. They are wonderful, wonderful lined up speakers. So have a great day and enjoy the educational event.
Thank you, Dr. Shaheen. That was great. Our first presentation is our menopausal hormone therapy and on the breast, and it's Dr. Michelle Jacobson. She is one of Canada's leading experts in menopause care, a respected OBGYN and menopause specialist based in Toronto. She's a co-founder of the Coven Women's Health, a virtual clinic that provides collaborative personalized care for women navigating perimenopause and menopause, and the chief of OBGYN for Osler Health Systems. She is the lead author of the Society of Obstetricians and Gynecologists of Canada, Clinical Guidelines on Menopause Management for Individuals with Breast Cancer and Hereditary Cancer Risk. Dr. Jacobson is also a board member of both the Canadian Menopause Society and the Menopause Foundation of Canada. Please welcome Dr. Michelle Jacobson.
Thank you, everybody. Please let me know if you can't hear me or if you can't see me. I am giving this talk from not my home because I'm giving a talk later this morning here in Ottawa, so I'm at the mercy of the Wi-Fi here. Welcome, everybody. I hope you're warm in your homes. If you're having hot flashes, you're in good company, and that will keep you warm. We're going to do a bit of an overview today on all the different aspects of breast cancer, hormone therapy, non-hormonal therapies, and why we make the choices and recommendations that we do. These are my disclosures and our objectives for today. So first of all, to understand the factors and demographics that influence the severity and frequency of hot flashes and night sweats, which are vasomotor symptoms in the cancer setting. Delve into some of the details around hormone therapy and breast cancer risk, whether that's causing breast cancer, associations with breast cancer, or how to treat women who've had breast cancer with hormone therapy or without, and review some of the current approaches to managing vasomotor symptoms in those with breast cancer and at risk for breast cancer. So I don't think I have to tell you this. It sounds like this is a group who's very, very well versed in breast cancer, and especially in Canada. This is the second most common cancer in Canada, the number one cancer that affects women, and responsible for the leading cause of cancer diagnosis in women under age 50. So we have excellent survival because we've got excellent screening because of people like you. And the likelihood of surviving a very early stage breast cancer is actually approaching 100% now because we pick up our cancers early. And yet, when we treat young women premenopausally with cancer treatments, we often have menopause as a side effect of the cancer treatment. On top of that, for ER-positive breast cancers, we often use medications like tamoxifen and aromatase inhibitors, which also confer gynecologic side effects that are associated with menopause that make the symptoms even worse and harder to treat. So when we use tamoxifen, we get risks to the uterus of hyperplasia and cancer. And one of the side effects of tamoxifen is hot flashes, on top of the hot flashes women may already be getting if they were perimenopausal or if they've gone through chemotherapy or if their ovaries have been suppressed with medication. And for aromatase inhibitors, we have to suppress our premenopausal patients and put them into menopause in order to use an aromatase inhibitor. So sometimes I'll get consults, requests from from folks, and they're urgent, and they say, oh, please see this patient urgently. You know, she's got ER positive breast cancer, and I need you to take out her ovaries right away, because if you don't, she's going to have to go on medication that puts her into menopause, and the side effects are really, really hard. And what I hope we all take away is that the side effect of medicine that puts you into menopause is menopausal symptoms. And those symptoms are abrupt, and they can be quite severe, and hot flashes are by far the most common. But the side effect of those medications, GnRH agonists like Lupron or Zoladex, is the same as if you take ovaries out and plunge a woman into surgical menopause, especially prematurely. So there is no difference in side effect burden. In fact, sometimes women don't respond to GnRH agonists. They continue ovulating. And for those women, we actually have to do surgery in order to get effective menopause. And the reason we do this is twofold. One is so that we can lower their total body estrogen production as part of their breast cancer treatment. And the other is so that we can use aromatase inhibitors, which are a very, very potent way of preventing breast cancer recurrence in ER-positive breast cancer. But of course, if we have women on ovarian suppression, this is going to be a rapid surgical or chemical menopause. The side effects include all the side effects of premature menopause, like vasomotor symptoms, but also the side effects of cardiovascular disease, early cognitive decline, bone thinning and aging, and all this is happening behind the scenes. And the side effects of the AI specifically include hot flashes, joint pains, and significant vulvovaginal pain. And these tend to be the symptoms that cause women to complain the most, or even to be non-compliant with their therapy. Why do we use these medications if they're so awful? We use them because they work really well. So if you have young women who have breast cancer, ER-positive breast cancer, and you look at the different options for treating them, the text in the soft trials showed us that if we put women into menopause and then use aromatase inhibitors, we are going to get the best cancer-free years afterwards. Tamoxifen works as well, not quite as well as aromatase inhibitors, but tamoxifen still works with ovarian suppression. It works on its own without putting a woman into menopause as well, but again, not as strongly as menopause plus aromatase inhibitor or menopause plus tamoxifen. So if you have young premenopausal women with ER-positive breast cancer, the younger they are, the more breast cancer recurrence benefit they will get from going into menopause and being treated with these medications. And the problem is they work really well, so we want women to stay on them, and yet it's very, very common to get menopausal side effects. So about 50% of women, regardless of their stage in menopause, when they start an aromatase inhibitor, will get hot flashes. And what this does is it impacts patient compliance. Sometimes they don't even tell you that they're not being compliant anymore. Because what we see if we follow women and we check blood levels for their aromatase inhibitor is that women are actually stopping to take their aromatase inhibitors. And when you ask them why, they tell you it's because of the side effects, whether that's the musculoskeletal side effects like joint pains, the hot flashes, or the vaginal dryness and pain. So if we know, and this is Canadian data, that hot flashes are so common and vaginal dryness is so common in these women, we know that the majority of them get female sexual dysfunction. We know that the majority of them get severe vasomotor and sexual related side effects. What does this mean for us? Well, it means that 84% of women on endocrine therapy for breast cancer are experiencing these symptoms. There's no difference in age. Younger women tend to experience them more severely, but the frequency, the prevalence is the same. That there is a paucity of physicians, at least, who ask about these symptoms, and that leads to 10 to 15% of women going off of their endocrine therapy. So we need to get better at treating these symptoms so that we can help our patients stay on their therapy and not get cancer recurrence. This is going to happen to over 30,000 premenopausal women per year who are symptomatic from their chemotherapy or their surgically induced ovarian insufficiency. So why does this happen? Why do the hot flashes happen? The reason this is important to understand is because we now have targeted therapies that we can use for women who have contraindications to using hormone therapy. So now we understand in the hypothalamus, there's an area called the KNDy neuron. And the KNDy neuron has a bunch of receptors on it. Estrogen is one of them. Neurokinin is one of the others. It's called KNDy because of the names of the receptors, kisspeptin, neurokinin, dynorphin. And we can take advantage of these receptors in order to modulate the effect on hot flashes. So we now understand that when estrogen levels drop, this area called the KNDy neuron grows, it hypertrophies, and it starts to send disproportionate signals to the area next to it called the thermoregulatory center. The thermoregulatory center lives in the median preoptic nucleus in the brain, and it is responsible for telling your nerves whether to cause your blood vessels to constrict or to dilate. And so if it is being signaled inappropriately, it is going to signal your blood vessels to dilate inappropriately. And this is going to lead to a sensation of flushing, sweating, becoming red, just like you just ran a marathon, except you're doing it inappropriately, not in response to the right temperature. If we give estrogen back, we can get this KNDy neuron to shrink back to normal size, and it will stop disproportionately impacting the thermoregulatory center. But we can't give estrogen, or we shouldn't give estrogen, to women who have contraindications like a history of breast cancer. So that leaves us with this gap of needing to find alternate pathways to enact the same change in the KNDy neuron that estrogen does. And because there are these other receptors, we can take advantage of that. So now we understand that giving neurokinin causes the same reaction as taking away estrogen. Therefore, blocking neurokinin will lead to the same outcomes as giving estrogen. And now we have available, well, not available, but approved by Health Canada, 2 neurokinin antagonists that will do this very thing. When we block the neurokinin, the KNDy neuron will shrink back to normal size. It will stop inappropriately signaling the thermoregulatory center, and we will get less hot flashes. And they are so effective that they work as well as giving estrogen for the same problem. They don't help with the other things that estrogen does, which we'll talk about, but they do help with the hot flashes, which are a big complaint for our breast cancer population. So let's take a step back and sort of look at what hormones do in terms of risk of breast cancer. Because one of the big, I would say myths, but it's not really a myth, that I think our patients and perhaps ourselves are under is hormones cause breast cancer, which is a very simplistic statement and, like everything, a very nuanced idea. So if we look back to the WHI, which is the largest clinical trial we have that really has guided decision making around prescribing and around perceptions of hormone therapy for the last 25 years, what we saw are women divided into 2 categories. Those who had a uterus were given estrogen, conjugated estrogen, which is Premarin, plus medroxyprogesterone acetate, which is Provera, a synthetic progestin. Women who didn't have a uterus because they'd had a hysterectomy were put on conjugated estrogen alone, Premarin alone. We saw in the first 5 years that the trial was running significant differences in cardiovascular outcomes, which actually led to the trial being stopped earlier. And we saw significant increases in the amount of breast cancer seen in the group of women who took estrogen with progestin, which also was publicized in a very inappropriate way when the findings were being publicized. Later down the road, when the WHI was looked at a little bit more clearly, they divided the groups of women into 2 groups. Those who were closer to their time of their menopause, so in their 40s and 50s, and those who had been menopausal for more than 10 years, so in their 60s and 70s. And they saw major differences in the outcomes in these 2 groups. So the women who were younger had less cardiovascular disease outcomes and had better all-cause mortality. And the women who were older had more cardiovascular disease like heart attack and stroke. So this kind of led to this window of opportunity hypothesis, which tells us that for women who are close to the natural age of menopause or under 60, that giving hormone therapy does not confer significant increased breast cancer cardiovascular disease risk. But what about the breast cancer piece? So for the women who were on combination therapy, it was publicized that this increases the risk, that hormone therapy increases the risk of breast cancer significantly. They published it in terms of relatives. So, they would say there was 100% increase in the breast cancer seen if two people got breast cancer instead of one person in the placebo group. So this is a very manipulative way of information when you share it in relatives. So it's really important to focus on what the absolute risk was. So even in this trial, where the worst hormone therapies were used, because we know synthetic progestins are the worst for breast cancer risk, we saw a risk of 0.08% or 8 per 10,000 women per year, and that risk returned to baseline after stopping. Later, after 20 years, this data was looked at again, and the women who'd had a hysterectomy and took conjugated estrogen alone actually ended up having less breast cancer even than women who had taken placebo. So there's something interesting about conjugated estrogen that does not confer increased breast cancer risk. And in fact, in the general population, like from the WHI, and even in the high-risk breast cancer population, the BRCA carriers, we actually see less breast cancer for women who take only conjugated estrogen. So this is really interesting, and it makes sense because conjugated estrogen is about 200 different types of estrogen all mixed together, and they act differently at different parts in the body. Some of them can probably be antagonistic or blocking the estrogen receptor at the level of the breast. Meanwhile, when you give estradiol, which is the bioidentical sort of in fashion estrogen that everybody wants to be taking right now, this is purely agonistic at the level of the breast, which is not to say that it causes breast cancer, but when you compare these two molecules, they are not the same. And you can't extrapolate from the WHI and apply this to information around giving estradiol alone. The findings from the WHI really only apply to conjugated estrogen. We have other studies that tell us about breast cancer risk. None are as big or as robust as the WHI, but there was a large study called the E3N that looked at about 80,000 women, and this was prospective data, so not a randomized control trial, but instead just followed women, but it was large, so you can sort of depend that the results are still valuable. And what they found is women who took estradiol, so that purely agonistic estrogen with a synthetic progestin, did have an increased hazard ratio of breast cancer in the first 5 years, whereas women who had taken estradiol with cyclic progesterone, the same bioidentical progesterone that your own ovary would make and given cyclically, did not have an increased hazard ratio of breast cancer seen in the first 5 years. So this sort of further lends itself to the idea that micronized progesterone or bioidentical progesterone is better for breast cancer risk than the synthetic progestins that were used in the WHI. Unfortunately, even in the E3N study, after 5 years, there was still an increased hazard ratio of breast cancer seen. So if we wanted to answer the question very simply of whether hormone therapy causes breast cancer, the answer is yes, there is an increased risk of breast cancer from using most types of hormone therapy. However, conjugated estrogen alone does not seem to confer an increased risk of breast cancer. It actually confers a lower risk. And we have other medications on the market now that we didn't have 20 years ago that were studied that have only really been available for the last 5 to 10 years that perhaps have a very different profile from breast cancer risk. And I'll show you what they are. The other important takeaway here is that breast cancer risk from hormone therapy is a very small risk compared to many other things that women do or don't even think about and do routinely. So if we use hormone therapy, E plus P for more than 5 years, we see a relative risk of about 1.3. So 1.3 higher time of developing breast cancer than if women didn't take any combination hormone therapy at all. This is comparable to women who go through menopause later than 55 years of age. It's comparable to women who are overweight after menopause or who drink more than 2 alcoholic beverages per day. It's comparable, it's actually less of a risk than women who have their first pregnancy after 35 years of age. And it's way less risky than having a relative with breast cancer, having gone through chest wall radiation, for example, due to lymphoma. And if you compare that risk, the risk is 1.3 for hormone therapy, and carrying a BRCA gene increases that risk to 200-fold. So we're talking about major differences, and I would argue, based on this information, that breast cancer risk conferred from hormone therapy has been overstated in the literature and in sort of the general population. And we have focused too little on the modifiable risk factors that would probably bring our risk lower than if we, were taking just the hormone therapy and not thinking about it. So we've sort of gone through this already. I want to talk a little bit more about some of the changes that happen in the breast when you take hormone therapy. So breast density is a surrogate measure of breast cancer risk. It is a way that you can hypothesize breast cancer risk from an intervention, because as we increase breast density, yes, women will get more breast pain, but also breast density is responsible for missing breast cancers and for having just a higher risk of breast cancer in general because there's more breast parenchyma there. So I said I was going to talk about a medication that's newer, and it's called the TSEC, or the tissue selective estrogen complex. This includes conjugated estrogen, so that good estrogen that we saw in the WHI used, but instead of using a progestin for endometrial protection, this uses a medication called basidoxifene. And the basidoxifene is a SERM, just like tamoxifen is. So by definition, it is antagonistic or good for the breast. But what's special about basidoxifene is it also is protective against endometrial cancer. So you can take advantage of its selective properties and combine it with conjugated estrogen so that the lining of the uterus doesn't grow too thick, even though women are getting exposed to the conjugated estrogen, and you don't have to use a progestogen for endometrial protection when that progestogen is the thing that has been implicated in the breast cancer risk piece over all the studies that we've talked about. So when we give conjugated estrogen with basidoxifene, we see no increased breast pain. We see no increased breast density, and this tells us that there is very likely to be less breast cancer. What's more interesting even is there was a very recent study that was done and presented at, I want to say, at ASCO in the spring, where women who had DCIS were given this molecule as they waited for surgery, and they actually saw regression of the tumor while women were waiting for surgery. So I am not a proponent of giving women with a history of breast cancer, especially ER-positive breast cancer, hormone therapy, but in the circumstances where this is appropriate, or for women who are high risk and want to be cautious but still want to use hormone therapy, choosing this medication, the TSEC, may be the best option comparatively. And here we see the higher the breast density, the higher the relative risk of cancer. Even more than that, what we see is as the breast density increases, and you know this already, the breast tumors are harder to see. I have a colleague, Melinda Wu, who has a slide that shows a snowman in a snowstorm, and when it is sunny out, you can see the snowman no problem, but as it gets windier and snowier, the snowman becomes obscured, and that's what we see, of course, with increases in breast density as well. Hormone therapy, like the usual, combination traditional hormone therapy, does confer a change in breast density that is negative. So this has been looked at by the PEPI trial that looked at a bunch of different combinations of hormone therapy. So as expected, when women were given conjugated estrogen alone, there was no statistically significant increase in breast density seen, and that is in line with the data that we've talked about. But when estrogen, and this was conjugated estrogen, so the one that is better for breast density changes, was combined either with synthetic progestins or with micronized progesterone, which you see in the purpley blue here, we did see a statistically significant increase in breast density changes. So what we take away from this is that the TSEC or conjugated estrogen does not increase breast density at all. There's another molecule called tibolone, which isn't included here, but it increases breast density very minimally, about 2%. And our traditional combination hormone therapies increase breast density closer to 15 to 20%. And this is important because breast density is not only a factor in breast cancer risk, but it also makes our breast cancers be diagnosed later with a worse outcome. And so here we're comparing the TSEC, so the conjugated estrogen with basidoxifene, to conjugated estrogen with synthetic progestin. The dark purpley blue is the synthetic progestin, where we see an increase in breast density. And actually, whenever basidoxifene was included, we see below the 0 line. So actually, not statistically significant, but less breast density. So this is a protective medication. There were other studies that looked at large groups of women, typically using registry trials to say, again, what is risk of breast cancer when hormone therapy is used? This one got a lot of press, so I think it's just important to mention. The key result finding here from this meta-analysis is after 5 years of a variety of different hormone therapies, if women started at age 50, we would see an increased risk of breast cancer for women who were using estrogen alone of 1 in 200. And again, this was including women who took estradiol estradiol, that pure agonist causes breast duct elongation and proliferation. 1 in 70 users who were using estrogen with cyclic progestogens. So here the breast gets a break from the progestogen. So there is still more breast cancer seen, but not as much when the progestogen is given daily. And here we see 1 in 50. And there was no women who were using that TSEC molecule included in this data. This was either estradiol or conjugated estrogen and cyclic progestogens, which could include micronized progesterone and could include synthetic progestins. So a big problem when you're interpreting the data on breast cancer and hormone therapy is it's very heterogeneous and it doesn't break down the data based specifically on the type of hormone therapy used. And we now have a better understanding that the type of hormones actually matter. Tibolone, told you I would tell you about. This is the one that increases the breast tenderness and density by about 2%, similar to placebo. So statistically significant, but arguably maybe not clinically relevant. And it tends to impact the breast receptor just at the level of the alpha receptor and the estrogen receptor. So this tends to be a little bit better from a breast cancer risk than giving pure estrogen. Tibolone is a steroid precursor molecule, so it's a cholesterol molecule that is taken and then it is metabolized into estrogen, progesterone, and androgen by the liver. So it isn't comparable in terms of the type of estrogen to any of the others that we have on the market. Now, what do we do with women who've actually had breast cancer? Well, in general, if you look at any chart and any guideline that talks about contraindications to hormone therapy, women with a history of breast cancer, be it ER positive or ER negative, is contraindicated to give hormone therapy. This is for systemic symptom management. So here we would want to use non-hormonal therapies to control our symptoms. This is not talking about genitourinary syndrome of menopause. So for women who have dryness in the vagina, pain with sex, bleeding, it is fair and reasonable to use vaginal estrogen or vaginal DHEA to treat the local symptoms to help women stay compliant with their aromatase inhibitors. And we have very large systematic reviews and meta-analyses that tell us that there is no increased risk of breast cancer recurrence from using vaginal estrogen. This is a big sticking point because it is a huge concern for women, how the painful vaginal symptoms that they get, and yet they're being told a lot of mixed information. So if they see people like me or they read guidelines out there, it says that it's safe to use vaginal estrogen, and yet a lot of I find surgical oncologists, less and less medical oncologists, but it still depends on the person, will say absolutely not, no estrogen whatsoever. This really is an outdated way of thinking, and it doesn't follow the data because we have a lot of data. That could be another talk for another time. We don't give systemic hormone therapy after breast cancer because of 2 randomized control trials. So there were many observational studies that looked at using hormone therapy after breast cancer, and observational trials or studies tend to be quite biased, and we see that in our observational studies because prior to the randomized control trials, the recommendations out there was that it was safe to take hormone therapy after breast cancer. So back in the year 2000, that's what the guidelines told us. Then in the early 2000s, there were 2 RCTs done out of Stockholm, Sweden. One was called the Stockholm trial and one was called the Habits trial. Both used estradiol and they used different types of progestogens. One used medroxyprogesterone acetate cyclically, that was the Stockholm trial, and the other used norethindrone acetate continuously. While the Habits trial was stopped early due to the increased risk of breast cancer seen, and the Stockholm trial was stopped because the Habits trial was stopped. What they later found was that even in the Stockholm trial, which didn't show short-term increased breast cancer risk, after 10 years they followed those women, they did see an increase in the contralateral breast cancer risk as well. So these RCTs told us that taking hormone therapy, at least the hormone therapy that was given to these women after a history of early ER-positive breast cancer, does cause an increased risk of breast cancer recurrence locally, so either in the ipsilateral or the contralateral breast. We didn't see any distant metastases, and this didn't include women who had had a double mastectomy. So how do you apply these data to our very young, let's say BRCA carriers who undergo double mastectomy? You can't really, but you do take away from this that there is risk conferred by taking systemic hormone therapy after breast cancer. And a similar study was done with tibolone, which very interestingly only went for a year and did show an increased risk of breast cancer recurrence in the ER positive group. They did not see an increased risk of recurrence in that year in the ER negative group, but I think arguably this is a very short amount of time to follow women when the question is recurrence. So what do we do then for women who are symptomatic and shouldn't or can't take hormone therapy? Here we have to look at other options that are available for treating vasomotor symptoms. This comes from the North American Menopause Society, which is now called the Menopause Society, and it's an open access article from 2023. It's a position statement on non-hormonal therapies for vasomotor symptoms. They break this down based on evidence, so they're not saying that you shouldn't do exercise or yoga or cooling techniques. Obviously, that's an asinine statement, but they're saying that there isn't strong evidence that doing yoga decreases vasomotor symptoms. It might still help with your sleep, your cognition, your stress, your mood, but it doesn't help with vasomotor symptoms specifically. The things that do include certain antidepressants like SSRIs and SNRIs. Not all of these are created equal. So Paxil or paroxetine, which has been rebranded in the States as Brisdel as a treatment for breast cancer or for breast cancer-induced vasomotor symptoms, shouldn't be taken with tamoxifen because it interferes with the metabolites. SNRIs include venlafaxine and desvenlafaxine, and these tend to have the best success rates at decreasing vasomotor symptoms. Gabapentin can be helpful, but can be very sedating and can cause more sleep apnea, so we have to be careful where we use this. Oxybutynin is an anticholinergic that is used primarily for overactive bladder, but it helps to decrease sweating. Of course, we worry about polypharmacy in our older patients and cognitive decline, and there can be a lot of unpleasant side effects with anticholinergic medications. And then the game changers, the one I talked about earlier today with the neurokinin antagonists, those are the ones that really, I think, are the future of treating vasomotor symptoms in women with a history of breast cancer. Fezolinetant is the one that is currently approved and available for prescription. It has been for about a year, but we have to do liver test monitoring while women take it. Elinzanetant has been approved by Health Canada, but is not quite yet available. What's interesting about elinzanetant is that it has been studied in women with induced vasomotor symptoms with breast cancer, taking tamoxifen or aromatase inhibitor. It's found to be effective and safe, and actually in Europe, the label includes using it for women with a history of breast cancer. We don't have that here from Health Canada yet, but I think it's possible we'll get there in the future. So keep in mind that even though we've been using fezolinetant for the last while, it is not actually approved for use in women with breast cancer, nor is it studied. There is a study that is going on right now, but we don't have the conclusions from it yet. Elinzanetant, which is not yet available for prescription, but will be and is approved, does have that study in women with a history of ER-positive breast cancer. The guidelines, which will be rewritten this year by myself and a team, go over all the things that we just talked about, except that we didn't have the neurokinin antagonists available, so they are not mentioned in the older guidelines, but they will be in the new. I'll reiterate that I think this is the most important takeaway message from today, that the genitourinary syndrome of menopause can be treated with a combination of moisturizers, lubricants, pelvic floor physiotherapy, and hormonal therapies in the vagina, whether this is local vaginal estrogen or some of the newer options like vaginal DHEA, which actually does not have a recommendation against use in breast cancer, and oral ospemifene, which is also a SERM and a very interesting molecule used for treating vaginal dryness that included women with a history of ER-positive breast cancer remote from treatment in their clinical trials. So I can give a whole nother talk on the treatment of GSM in women with breast cancer, but I do think it's important to manage and to mention. I'm going to stop here and take questions. This is the last thing that I'll say, and that is that we've talked a lot about symptomatic management, and women with a history of breast cancer are often very worried that they can't take hormones and that they are missing out on all the benefits of hormones, especially with the way the pendulum has swung on talking about menopause. It is really important to tell our patients, and perhaps some of you are patients yourselves listening today, that yes, it is, we want to listen to your symptom burden and we want to get creative in treating them in a safe way. But probably the most important part of menopause from a longevity and a wellness perspective is paying attention to the asymptomatic things that are happening. So making decisions that are hard to make, but that help with healthy hearts and healthy brains, like maintaining a normal body weight, tight glucose and lipid control, exercising and decreasing smoking, treating diabetes, getting better sleep, dealing with your mood, whether that means therapy or picking up a hobby or exercising more, whatever it is you need to do. These have evidence for significant improvements in your wellness and your mortality. And it is not all about hormones and vasomotor symptoms. And I hope that that's a positive message that we can bring back to our patients. So I'm very happy to take questions.
Michelle, that was such a great and very informative presentation. Thank you so much. If anyone has questions, please just a reminder to put it in the Q&A function. I can't tell you, Michelle, your slide on hormone risk is so helpful to me as a mammographer. And I know I get a lot of questions from a lot of my screening patients about HRT causing breast cancer and what are the risks. And this put it in very good perspective. So thank you so much.
My pleasure.
Namisha, have we got any questions yet? No questions. If you have any questions, either raise your hand or put your questions in the Q&A, guys. I'll just give it a minute more, Michelle.
Absolutely. And I'm happy to also just mention that, cancer survivorship is, I think, a very important part of cancer treatment, and it's an evolving area of interest. Access is still a major problem, and in Durham region, there is no menopause expertise. I don't want to have that taken the wrong way. I'm sure there are wonderful family doctors and gynecologists who are interested in managing menopause and who are certified in managing menopause. But in terms of very formalized cancer survivorship programs, there isn't one that I'm aware of in Durham region, and it would be great to have one. I do take referrals downtown. I've got a very long wait list, but very happy to see women virtually for these kinds of concerns. And I also started my private clinic, Coven, so that women could have access with no barriers and no waits. So the barrier is cost, but if they have private insurance, it is covered. They see a nurse practitioner, dietitian, social worker to give that sort of holistic, multidisciplinary care that I think is so important. Our social worker is a breast cancer survivor herself, and she does a lot of the cognitive behavioral therapy for insomnia and for hot flashes. That is really hard to find someone who's knowledgeable about it. So our cancer survivorship stream, I think, is one of the things that sets us apart.
Okay, I don't see any questions. I think you answered them all.
Great.
This was fantastic. Thank you so much
Thank
for
you.
joining us today.
My
and
pleasure.
Keep warm.
Thanks, you too. Have a
Oh,
great
there is a
event.
question. Oh, wait, I hear there's a
Oh.
question.
Let's see. Is there a role for soy, such as soybeans, for women to mitigate menopausal symptoms? That's a great question. So there is evidence that soy-based supplements can help with vasomotor symptoms, but not food, because you'd have to get a very high concentrated amount in order to help with symptoms that you can't really get just from eating, let's say, soybeans or tofu or something like that. What we don't know is if we are taking it in hyper-concentrated form that it helps with hot flashes, are we just metabolizing that to estrogen, in which case it wouldn't be safe in the breast cancer population. So it's a complicated answer. That's both a yes and not for this population.
Great, thanks, Michelle.
No
Any
problem.
more questions, guys? I'm not seeing any more. Thank you, Dr. Jacobson. Thank you so much.
My pleasure. Have a great day.
So our next speaker is Siobhan Wood. Siobhan is a registered dietitian and certified diabetes educator, specializing in evidence-based nutrition for chronic disease prevention and women's health. With more than a decade of clinical experience in primary care and home care, Siobhan has worked with hundreds of people looking to improve their diet to reduce their cancer risk, support their journey through cancer treatment, or recover from cancer. She is the founder of Well Balanced RD, where she provides nutrition counseling, group programs, and community education focused on gut health, metabolic health, and women's well-being. Please welcome Siobhan Wood.
Hello. Glenda, is my screen sharing?
I can see your screen.
Yeah, okay.
Yeah, looks good.
Okay, great. Okay, thanks for having me this morning. I'm very excited to be here to talk about dietary strategies that we can use to support breast health, specifically breast cancer risk today. So today I'll be going over a few different learning objectives. So we'll be talking about evidence-based dietary factors associated with reducing breast cancer risk, mainly focusing on fiber intake, plant-forward diets, addressing concerns around soy and a few other factors. I'll be talking about explaining the role where we're looking at the link between nutrition and metabolic health, body composition, gut health, and estrogen metabolism for breast cancer prevention, and identifying dietary recommendations that clinicians can use to, speak with patients about if they come in with questions regarding diet to support both their breast health and long-term cancer prevention. And Glenda gave me a lovely introduction, so thank you. So why this topic matters. So as I'm sure many of you know, the prevalence of breast cancer in Canada is quite high. And from what we know, about 30 to 40% of cancers are linked to modifiable lifestyle factors, with things like body composition, diet, and physical inactivity being some of those top 3 factors. And so I know smoking cessation and alcohol are also coming up today, so those are up there as well. And nutrition specifically affects estrogen exposure, insulin, and IGF-1 signaling, chronic inflammation, body composition, gut microbiome, and all of these things are linked to breast health. So we will be going over those. Generally speaking, one of the most important messaging that I like to speak with patients about if they're coming in and worried about breast health, breast cancer risk, is that dietary patterns matter a lot more than just one singular food. So very often people want to know what's the one food that they can be eating or including, or the one food that they can cut out or avoid. And based on the evidence that we have, it's not about one singular food. It's really about the patterns and how those over time add up and can contribute to risk. So things that we'll be looking at today are Mediterranean style diets and the research around that, which really ties into plant-forward eating, a higher fiber intake, and lower ultra-processed food. So plant-forward diets and breast health, there is consistent evidence to show that plant-forward diets are associated with lower incidence and recurrence of breast cancer. And that can be simply like a shift towards increasing plant-based intake. So it doesn't have to mean that somebody is becoming vegetarian or vegan. They don't need to kind of fall into this all or nothing pattern in order to see benefits from this. So simply increasing the amount of plant-based foods that people can add into their diets does still yield the benefit when we're looking at breast cancer risk and overall breast health, among many other health conditions. So breaking that down a little bit, one of the factors that comes along with increasing plant-based foods is fiber intake. So fiber intake and breast cancer risk has quite a bit of evidence here. So we find that higher fiber intake is associated with lower circulating estrogen. And on the next slide, I'll get a little bit more into this. Improved insulin sensitivity. And later on, I'll also talk about how that is linked to breast cancer risk and breast health, and reduced inflammation. And so from what studies have found, there's about a 5 to 10%, most commonly the numbers are usually around 7 to 8% reduction in breast cancer risk per 10 grams of increased fiber a day. And I'll show you what that looks like. But most North Americans get studies show less than 10 grams a day, usually around like 5 to 7 grams. And the recommendation, across adult populations is at minimum 25 grams a day. So in Canada and North America, we're really kind of missing the mark as a population with our fiber intake.
Siobhan, sorry to interrupt.
Yeah.
The slides are just a bit blurry, so I'm wondering if you go off camera, that might help.
Okay.
Sorry.
That's okay. If I go off camera, so I'll shut my camera off.
Perfect. And then try resharing again.
Okay. Let's see. Any different?
Not a ton, but we will go with it. No problem.
Do you want me to try? One sec. If let's see if this shows up any better. No, I don't think that's going to work. Okay, sorry.
No, that's okay.
Okay. Would the copy that you have show up any better, do you think?
We can definitely try that. So just give us 1 second. Siobhan, maybe keep going and we'll try and work on it on our end of things.
Sure. Okay, sounds good. All right, so back to fiber intake and how this can affect breast health and breast cancer risk. So really looking at estrogen metabolism here, and I'm not sure what you can see right now on the slides, but this image that I have up on the screen is directly from the study that I have cited here below. So it's associations between dietary fiber, fecal microbiota, and estrogen metabolism in postmenopausal women and breast cancer. And this really helps to highlight the way that increasing fiber can affect breast cancer risk. So higher fiber intake is found to actually bind to estrogen in the gut. Fiber also helps to improve gut motility, so moving things through a little bit quicker. And then as a result, it leads to increased fecal excretion. So helping with that circulating estrogen and helps to lower those amounts. And from what the studies have found, there's an inverse association between the soluble fiber and estradiol levels. So pretty interesting kind of link there. And when we're talking about fiber, so increasing fiber, if you have a patient or client coming in and they have questions around their diet and whether that's, they have found out that they're at increased risk, they're going through having a family member diagnosed, they've been diagnosed themselves. One of the key things that I find really helps people is focusing on what they can change and making sure that the recommendations feel really realistic. And so increasing fiber tends to be one of those things that's a good starting point when it comes to diet and breast cancer risk. So high fiber foods and tips. Fiber is found mostly in our whole grains, fruits and vegetables, legumes, nuts and seeds. And what I like to highlight for clients is really increasing gradually. So for somebody who maybe has a very low fiber diet to begin with, if they are looking for something to change because they're worried about their breast cancer risk, I do try to avoid people going from very little fiber to a ton of fiber because that can cause quite a bit of GI distress. So slowly increasing the amounts of fiber and making sure that they're pairing that fiber increase with fluid. So you don't want one without the other, or people will end up with a very upset stomach. Constipation can be a very real issue. So doing that gradually, and what that can look like is a variety of things. So if people are open to trying legumes, I find that in North America, this is, you know, the one group with high fiber foods that tends to be very low consumed, but great option for increasing fiber, whole grains, fruits and vegetables, nuts and seeds. And even if they can choose one of these options and start to add it in a little bit more regularly, that can be enough just to start to move them in the direction of going towards that 25 plus grams a day. So, you know, if they can choose legumes or if they can choose berries, and just choosing a serving a day could get them an extra 5-10 grams of fiber in their diet. That's a very tangible option for somebody to start to work on, and it helps them feel like they're in a little bit more control of what they can work on in terms of modifiable factors if they're worried about breast cancer risk or breast health. All right, soy. So often lots of questions about soy when it comes to breast health and breast cancer risk. So whole soy foods can act as weak selective estrogen receptor modulators, and longitudinal studies show no increased risk in breast cancer and possible reduced recurrence or mortality. So I do find that a lot of patients come in still with a lot of fear around increasing soy foods. And sometimes even questions from males who have family history of breast cancer. They're worried about soy because of, you know, previous myths around it increasing breast tissue in men. But I think there's a lot of good evidence to show that we can support people in trying to increase soy foods in their diet. And what that can look like is it doesn't have to be a lot. It's 1 or 2 servings a day. And I'll show you what that might look like if you're talking to patients or clients about this. But this breaks down, you know, different breast cancer subtypes, what the evidence shows, and then clinical interpretation of that. So the only one in terms of research that, you know, comes up as potentially concerning is the HER2 positive. There was one small study that did show increased risk of cancer with increasing soy, but it was a very small study. It doesn't seem to be consistently replicated. So in terms of overall clinical interpretation, even with that subtype, there's just insufficient evidence to recommend avoiding it. If people either are currently eating it, it might be a big part of their diet, or if they're interested in diversifying their diet and wanting to go, you know, towards that more plant-based diet option. So the biggest benefit seems to be with postmenopausal women. So the greatest benefit is seen with increasing or adding soy to the diet when women are postmenopausal. But generally speaking, you know, you can let patients or clients know that there's no increased risk found, and there's possibly even reduced mortality and benefits seen with whole soy foods. And again, I'm speaking here specifically about increasing soy foods in the diets and not necessarily supplements.
Yvonne, sorry, can I just interrupt real quick? We have your slides. Would you like us to share on your behalf?
Sure, yeah. Do you want to try them and see if they're more clear?
Does that work for you?
Yeah. Okay, great. Okay, so body composition and estrogen exposure. Way better. Great. Sorry, everyone. Okay. So looking at adipose tissue specifically and how that can affect breast cancer risk. So studies have shown that there's increased inflammation, insulin resistance, and growth factors that tend to increase with increased adipose tissue. And so I will get into insulin resistance and why that matters shortly. but there is the strongest association, again, with this and post-menopause. So because post-menopause, that's when we're seeing estrogen deriving from adipose tissue. So looking at body composition really seems to make the most difference post-menopause. With that being said, I do like to caution practitioners in terms of how you're approaching these conversations. I've had many clients come in who either have breast cancer, at increased risk of breast cancer, maybe recovering from breast cancer, and they have read some research, looked at information, and have found that there is that increased risk with higher adipose tissue. And they're very, very concerned about that. But that being said, I do find that it's important to let people know that it's equally as important to focus on overall dietary patterns and their activity levels and all of these other things that we can modify, rather than restricting so much just to get to a certain body composition. You know, maybe BMI is just above normal, just because it makes people feel quite discouraged, just depending on where they are sitting with body composition. So there's a lot of other factors that we can focus on to mitigate risk, and just acknowledging that adipose tissue itself is one of those things. Okay, next slide. So metabolic health as a cancer risk modifier, and this does tie into what I was just speaking about, but hyperinsulinemia promotes cell proliferation and inhibits apoptosis. So looking at how diet affects the glycemic load and insulin resistance seems to have a very strong risk with diabetes and breast cancer and breast health. So insulin and IGF-1 signaling pathways can increase tumor growth, and specifically type 2 diabetes has association with increased breast cancer risk. And that seems to be the chronic inflammation that's seen in metabolic dysregulation, causing, an environment that can promote that pro-carcinogenic environment. So next slide, we'll get a little bit more into this. Thank you. So type 2 diabetes specifically, as I said, is associated with an increase in breast cancer risk, and it can be quite significant. So studies have shown about 15 to 27% increased risk, just depending on if the study adjusted for BMI or not. And specifically, certain subtypes of breast cancer and certain populations seem to have an increased risk when they have type 2 diabetes. And metabolic syndrome itself and hyperinsulinemia, and so even without necessarily type 2 diabetes, are also linked to worse breast cancer outcomes and mortality. So this is definitely something to consider for patients who come in and either are also at increased risk of diabetes or have diabetes already, and looking at how we can better control their diabetes in order to help to reduce that breast cancer risk. I tend to have a lot of questions as a dietitian from patients who come in and have type 2 diabetes and are at increased risk or have breast cancer, asking about sugar, because if they've gone online and they've looked at a little bit of information, this whole concept around how sugar fuels breast cancer or cancer cells in general tends to come up a lot. And so what I like to tell people is that cancer cells in general use glucose just like all cells. So it's not a matter of having sugar and it's only fueling cancer cells, but the risk relates to that chronic hyperinsulinemia, chronic inflammation. So it's that dysregulation of their blood sugar, not just the fact that they're consuming sugar. So trying to kind of neutralize that, because what can happen, and not that I want people eating, tons and tons of sugar, but what can happen is that it creates a lot of fear in people, and they can swing the other way and really start to over restrict things. So just trying to neutralize it a bit in the way that explaining to them, we're just trying to create better control with blood sugar levels in general. Some other questions that tend to come up especially if people have diabetes or at increased risk of diabetes, and they're worried about breast cancer. Things like keto diets, are keto diets protective? And again, just letting people know that there's no strong evidence to support them for cancer prevention. Really, the evidence shows that fiber-rich or balanced diets have the strongest positive associations. Another one I hear a lot about or get asked a lot about is intermittent fasting, and is that protective? There is some mixed evidence on intermittent fasting, but but what we seem to find is that the benefits are coming from improved metabolic health in general, not necessarily from the timing or the fasting. And if somebody has diabetes and they're using insulin, it's something like intermittent fasting, could potentially cause issues, or we need to just very closely regulate what somebody is doing in terms of their insulin usage if they decide that adjusting their diet to some sort of fasting pattern is something that they're interested in doing. But it's not necessarily something at this point that I'm recommending to people. It really comes down to, generally speaking, when people engage in something like keto or intermittent fasting, they're changing their overall dietary patterns and compositions, and that seems to have benefits in terms of blood sugar regulation and inflammation and all of these things that we're talking about in terms of the link between diabetes or blood sugar and breast cancer risk. Okay, next slide. So looking at dietary patterns and specifically related to blood sugar control, something that is something that patients and clients can focus on is the glycemic load of food. So higher glycemic load, essentially how quickly foods break down and increase somebody's blood sugar, are associated with higher cancer risk, including breast cancer, and again, especially post-menopause. So if people have a diet that's very high in glycemic load, or they tend to have a lot of high glycemic index foods, what can happen is that they're having repeated glucose spikes, so blood sugar is going up quite quickly. That over time can result in chronic insulin elevation and then pro-growth signaling. So that's what we're trying to avoid. And some tangible things that people can start to work on is shifting from higher glycemic index food to lower glycemic index food. And these can be relatively simple shifts. It doesn't require them to overhaul their entire diet. Maybe switching from one type of cereal to another, switching from instant oatmeal to a steel cut oat, white rice to brown rice. Like, generally speaking, when it comes to dietary recommendations and changes, these are things that people can start to implement relatively easily without feeling overwhelmed. This is just a chart that I've made, but there's lots of resources online. Diabetes Canada has a glycemic index handout if you would like something for patients or clients. Okay, next slide. Okay, so looking at nutrition strategies to support metabolic health and reduce cancer risk. So generally speaking, based on all of the research that we have and looking at the patterns that seem to result in reducing cancer risk with diet, we're looking at using nutrition to support glycemic stability and insulin sensitivity for these patients who are at increased risk of both breast cancer and diabetes. So looking at those low glycemic foods, looking at high fiber carbohydrates, looking at increasing fiber, and you can explain to them, the way in which that works, the way that it helps with estrogen clearance in the gut, lowering glycemic load, and that can be either switching to low glycemic index foods or also looking at their overall dietary patterns and how they're putting foods together so that they're adjusting glycemic load based on the meals that they're eating, not just the singular food. So pairing their carbohydrates with protein, with fiber, with healthy fats also helps with glycemic stability. And then minimizing some of the ultra-processed foods, saturated fats, and sugar is beneficial for their breast cancer risk. Next slide. So the Mediterranean diet, this is in terms of a dietary principle or overarching guideline. Definitely one of the most well-researched options, especially when people would like something a little bit more clear to follow. You know, if they want some sort of quote unquote diet, something that they can really follow along with as they would like to make dietary changes, I like to direct people towards the Mediterranean diet. So it's a really high intake of fruits, vegetables, legumes, and whole grains. So again, really focusing on that high fiber intake. Olive oil is the primary source of fat. They've got regular intake of nuts, seeds, and fish, which generally tends to be quite low in Canada and North America, and really limited intake of red meats, processed meats, and ultra processed foods. And overall, what we find is when people eat in this way, they follow patterns like this, it's shown to decrease inflammation and improve metabolic health, which then all relates back to these factors that can increase or affect their breast cancer risk. Okay, next slide. Thank you. So looking a little bit further as to why the Mediterranean diet specifically seems to be a good option, it helps with this low-grade inflammation that seems to occur when people are eating diets that are low in fiber, high in saturated fats, high in ultra-processed foods, and that chronic low-grade inflammation can increase or amplify the estrogen production and signaling. It can affect insulin resistance and IGF-1 activity. Seems to affect just the overall environment of our body and how that then can lead to increased risk of breast cancer. And the Mediterranean style or plant forward diets in general, but they do tend to line up quite closely together. It's consistently associated with lower inflammation, lower inflammatory markers that we see done on blood work, improved insulin sensitivity. People tend to have better blood sugar control when they are eating in these ways, and tends to help to support a healthy body composition. And so specifically, again, with that postmenopausal breast cancer risk, this seems to be quite beneficial. And in general, studies have looked at Mediterranean diets or plant-forward diets and breast cancer mortality, and it seems to improve the rates of breast cancer mortality in certain cohorts. Next slide. Okay, so gut health and estrogen metabolism. This is something I would say I'm more recently getting questions about. So the estrobolome and the sort of gut bacteria community that exists in our gut and how it affects estrogen. This seems to be like a bit of a hot topic recently, at least with clients that I'm seeing. But talking about how gut health can alter circulating estrogen levels by regulating reabsorption. And so what I like to encourage people to focus on is, again, that fiber-rich diet and how that can support a healthy gut ecosystem to support that estrogen clearance. I do get a lot of questions about probiotics often when gut health comes up. And so from what studies have found, this far, maybe this will change in the future, but probiotics may help with specific symptoms in certain contexts, but they're not proven in terms of breast cancer prevention or anything like that. So yes, they do have some evidence in terms of gut health in general, but when it comes to breast health or breast cancer, it's not something that I am focusing on, really trying to get people to focus on that fiber and focusing on foods first for gut health and diversity there. Next slide. So in terms of just quickly mentioning certain vitamins or minerals, because this often comes up with diet, there's no specific vitamin or mineral that has sufficient evidence to recommend supplementation for breast cancer reduction. There are certain things in terms of vitamin or mineral status that are important for people. So things like vitamin D, iron, B12, iron for just immune function. Iron deficiency is common in breast cancer patients, especially if they're premenopausal. If people tend to make a shift towards plant-based diets to reduce the risk, we're also looking at things like iron and B12 and making sure that their levels are adequate. B12, again, specifically if people have type 2 diabetes and they're on long-term metformin use, that can be of concern. Low vitamin D specifically has been found to be associated with worse breast cancer outcomes, higher mortality in certain observational studies. So just making sure that vitamin D, especially in Canada, is adequate. So getting that tested and making sure people are supplementing accordingly. And then just a few other factors like physical activity, sleep, stress management. I know alcohol and smoking is all going to be talked about, but just from an overall lifestyle approach are all important too. Next slide. So key takeaways for clinicians, if you have people coming in and asking about diet in terms of their breast health and breast cancer risk, I mean, ideally, if you can connect them with a dietitian to explain things a little bit further, that's great. But as kind of a summary, focusing on increasing fiber. So, 25 grams a day is kind of minimum. More is better. The recommendations are even higher if people have diabetes. Promoting plant-forward dietary patterns, but without encouraging people or without, letting people know or think that they need to be vegetarian or vegan. Small shifts still make a big difference. If people have concerns around soy, you can safely let them know that they're welcome to include that in their diet, 1 or 2 servings a day, which is not much, like a third a cup of tofu is considered a serving, and supporting their overall metabolic health in terms of diabetes and the cancer correlation can also be a great way for people to focus on multiple aspects of their health. And just discouraging restrictive diets and unproven supplements. I do find that when people are looking for something to control or to kind of hold on to if something is going on with their health and they're feeling like things are really out of control, diet tends to be one of those things that people will cling on to, and people will either go all in really quickly and then not sustain any change because it was too much too fast, which isn't really beneficial, or they'll go all in and then end up too restrictive, which especially for people who maybe are currently receiving treatment for breast cancer can be detrimental in terms of how well they then tolerate treatment. So it is a bit of a balance, and the messaging around food and diet can have a pretty significant impact on people's relationship with food. So just being careful about how you're presenting information to people. And one more slide. So just as a wrap up, nutrition does modify breast cancer risk through multiple pathways. This was just a high level overview, but there is a lot that can be done with nutrition, and metabolic health specifically is a key prevention target. So nutrition interventions can address cancer prevention and overall cardiometabolic health. So just presenting it to people in terms of focusing on their overall health, and that can in turn help with breast cancer risk or breast health. And that patterns matter more than singular perfection. So what people are doing over time, long term, matters a lot more than hyper focusing on, a specific group of foods or 1 or 2 foods. So we're looking at using diet to lower chronic inflammation, not just through one single thing, but over time, and how that ties into your metabolic health and hormone signaling. And then that is everything. Last slide is just references. Thank you.
Thank you, Siobhan. That was a great presentation, very informative. It's a shame that your slides came out a bit blurry at the start.
I know, sorry.
I know, what a shame. And we couldn't see your beautiful face. So just to let everybody know, and there have been a few questions, we are going to share the slides, all the slides from this event at the end of it. I believe there are a couple of questions for you, and I have the envelope. Right. Okay. Your thoughts on supplements like Metamucil to help with fiber intake?
Yeah, so Metamucil does increase fiber intake. I wouldn't say it's an option. The downside of that is that increasing fiber intake through foods does kind of miss out on some of the other benefits that come with high fiber foods. So it is an option if people are struggling to increase their fiber through food, absolutely still has benefit. Go for it. But I would still encourage people to try to increase those higher fiber foods, the lentils, legumes, whole grains, fruits, and vegetables, because there's other benefits that come along with those that you won't get from Metamucil.
Great, so more naturally. Perfect. Another question, is there a role for soy, such as soybeans, for women to mitigate menopausal symptoms? Mitigate.
I think Michelle answered that in her presentation. I think that one came up. Am I wrong? I think she was talking about menopausal symptoms with soy.
She did answer it, yes. Yeah.
Okay, great.
And one other question, is there any link between polycystic ovarian syndrome and breast cancer where taking metformin to control sugars are used?
Ooh, good question. In terms of PCOS and breast cancer risk, honestly, I, off the top of my head, cannot speak to how strong that correlation is. In terms of metformin specifically, so using metformin just as like the drug itself, I can't speak to if there's a link between taking metformin and breast cancer risk. If somebody with PCOS also has high blood sugar, and that's why they're using metformin. Sometimes metformin is used in PCOS, even if blood sugar is relatively well controlled. It's used for other symptoms. But if blood sugars are high, then that, in terms of risk, would be the same as when we're looking at the risk with type 2 diabetes. It's the fact that high blood sugar contributes to that increased breast cancer risk. But PCOS itself and a breast cancer risk, I'm not sure like the exact data on that. And metformin itself, again, can't speak to that. But if blood sugar is high with PCOS, and often there is insulin resistance there with PCOS, then that would have the same link that type 2 diabetes, the same pathways.
Wonderful. We'll just give it another couple of seconds to see if there's any more
Sure.
questions. Not seeing any. Okay. If there's any more questions, what we can do is we can always send you them by email, and maybe
Sure.
you can respond to them afterwards. Siobhan, thank you so much for joining us today. Have yourself a great rest of the day.
Thanks for having me.
Our next speaker is Dr. Fawad Iqbal. After growing up and starting training out west, Dr. Iqbal completed his fellowship at the Mayo Clinic in 2009. Since then, he has been a radiation oncologist at the Durham Regional Cancer Center, primarily treating breast, lung, and GI cancers. More recently, at the prompting of his two kids, he started to become more concerned with cancer prevention and became interested in alcohol as an under-recognized carcinogen. Please welcome Dr. Fawad Iqbal.
All right. Good morning, everybody. I'm going to try and do my own slides. So let me see if I can share this properly, which I may not be able to. Share. Okay, are people seeing that okay?
It looks good.
Looks okay? All right.
Yep.
Okay. Great. Thumbs up. All right. Excellent. Okay. So, I mean, it was actually literally in the news yesterday. There was an op-ed from Iris Gorfinkel, if anybody listens to CBC. So she did a Toronto Star article. There is another paper, yet another paper comes out that says alcohol's probably not so good for you. So anyways, if anybody wants to read that, it was just in the news yesterday, Toronto Star. Sorry, I just have to clean up my screen. Okay, so we're going to talk a little bit more specifically about breast cancer. I did kind of scroll the list of attendees, and the names looked by far mostly female, but I'm going to throw in some parts for the guys as well too, so bear with me a little bit on that. There we go. Okay, and I think the land acknowledgement Sarah did at the beginning, so I'm going to say I'm in Markham, which was Anishinaabe territory for me particularly. I don't have any disclosures. I think the relevant part for this particular conversation is that I don't drink and I don't smoke. So in terms of kind of the social aspect of it, I was the designated driver type of person when we were out. So pretty much all my friends would drink or whatever, but I wasn't. Um, and yeah, I'll just go back to that story about my kids just for a second because my boys are 9 and 12 now. So, I talk about work at home in vague terms, and we were talking about smoking, and smoking is bad. And there's a whole other talk about smoking, so I'm not going to belabor that too much. But actually, my older son at the time, this was a few years ago, he was like, well, if alcohol's so bad for you, how come people don't pay attention to that? And I didn't really understand that. So that's when I started to kind of dig into it. And it's continuing. So we'll talk about kind of population level stuff, and then we'll get into some of the mechanisms. I'll also get this on the next slide too, but this is really not new information that alcohol can cause cancer. The original publication was from like 1911 or something. It was over 100 years ago. There was a publication about alcohol causing esophageal cancer. So this is not new information within kind of the scientific world. And if anybody's old enough out there, they might remember the More You Know campaign. But yeah, it's just the playbook of the tobacco industry is very obviously repeated by the alcohol industry, and you'll see that kind of thematically as I go through as well, such as celebrities. Okay, so officially though, alcohol was classified as a human carcinogen in 1988. So prior to that, there was evidence, but nobody really paid that much attention to it. There was a lot of focus on smoking since about the Nixon era was a lot about smoking. But if you look at kind of things that we know cause cancer, I mean, this is OBSP, so I'm guessing there's a lot of people on here who are MRTs. Radiation is right at the top of the list. Like radiation causes cancer. There is no doubt about that, right? We all know that. The mechanisms are very well established. Smoking as well. I mean, if anybody doesn't know that smoking is bad for them, like probably need to do a little bit of work. Things like asbestos as well. Like these are things I think most people, when they hear it, they're like, oh yeah, that's bad. I should avoid that. Whereas for alcohol, it's just so common and it's culturally kind of embedded that people don't really think about it. And I admit that myself. I didn't really think about it before. So, I mean, I'll go back to kind of that intro bit again. Like I grew up in Calgary. I went to med school in Alberta. Like people party hard in undergrad and med school. Like really, there's a lot of drinking that goes on. I'm not sure how it is now. Maybe the younger crowd is smarter, perhaps. But there was a lot of very heavy alcohol use in medical school. And at the same time, we would go to a talk about colon cancer or liver disease or whatever. And it just was kind of this mental disconnect of, oh, but we're going out on Friday night and everybody's going for drinks. So somehow tobacco was very obvious that, the education happened for decades prior to kind of my generation that, oh yeah, smoking is bad, don't smoke. Whereas with alcohol, it's just so embedded culturally and kind of normalization within social dynamics, people just didn't really think about it as like an actual, oh, this might not be so good. So I'm by no means like an abolitionist or anything like that. I'm like, if people want to have a drink, I'm totally fine with that, honestly. Like it's more just about quantities and understanding what's happening. But I'll just kind of go to my pictures there on the bottom. The playbook it's really the same, right? You have celebrity advertising. We got Gary Cooper back in the day. He prefers his Lucky cigarettes. And now we've got I'm blanking on the name. Ryan Reynolds. Ryan Reynolds has his own, used to have, I guess, his own alcohol brand. It's the same sales pitch, right? popular people doing cool things. Oh, I better get in on that crowd. It's all just basic advertising psychology. So this rather large document, I put kind of the summary bits at the bottom there. So this was from 1999. It was a huge document that was put together down in the States, really for kind of CDC level, government summary of what's going on. It's a very fascinating read, actually. So if anybody wants to take the time to read like 70 pages of stuff, it's really interesting, actually, kind of, just the mechanisms, and they go into kind of molecular stuff and animal studies and like all sorts of really detailed stuff that honestly I don't understand about half of it. But once again, this is from 1999, and here we are in 2026. So this isn't a new topic. And I mean, the general idea, and this is very consistently shown kind of around the world and within populations, within ethnicities, the more you drink, the more risk there is. And for breast cancer specifically, it is a risk that goes up with consumption. So that there's no kind of debate on it. I mean, with kind of many things, they're like, well, there's got to be a level where it's okay. Maybe there is, but we don't really know, right? So everybody kind of has to have their own kind of personal take on what they're willing to put up with in terms of their life. But the safe amount is 0. Like that's really, if you want the actual answer, the safe amount is 0. So a lot of the things you'll see kind of online and kind of within the alcohol research world come out of the UK. And I don't think this is being unrealistic to say this. Like, the UK has a pretty significant drinking problem. I think they recognize it, actually. And yeah, I mean, they have put a lot of work into kind of alcohol education on a population level. So some of my infographics here are from the UK. My text on the right, so each additional drink increases risk of breast cancer by 7 to 10%. That's a high number. Once again, it depends which study you look at, which population group you look at. So the kind of more average number that I've seen out there is if you have 1 drink a day, so kind of I have a glass of wine at dinner, so 7 drinks a week, that roughly increases your risk by about 14%, over your lifetime. So it's not huge numbers, right? Like, when you think about kind of relative risk, a 14% relative risk is not super high when it comes to things. And I mean, I'll contrast that against smoking, which is the next talk. But just in terms of straight numbers, though, and everybody here knows this, breast cancer is already very common. Like, as a baseline lifetime risk, same thing, depending which numbers you want to look at, 1 in 8, 1 in 9. That's kind of the numbers currently for North America for female breast cancer during lifetime. So 1 in 8 or 1 in 9. But I'm going to simplify the numbers because my brain is not that complicated, honestly. So call it 1 in 10, just for the sake of easy numbers, that 1 in 10 women nowadays is going to get breast cancer. And then same thing for just simplification of numbers. If you say, okay, a few drinks a week would increase my risk of breast cancer by about, call it 10%, depending which study you look at. So you've got a 10% baseline risk. You've increased that risk by 10%. So your absolute increased risk is about 1%, right? Which doesn't sound high, but essentially that's a 1% risk of coming to meet me in a professional status, right? Which I guarantee you, nobody wants to meet me in a professional status, right? Like, that is by far the worst day of most of these people's lives, is the day that they get told they have cancer, right? And it's usually not me doing the telling, by the way, it's usually a surgeon. But it's that whole concept of risk and tolerance and what's acceptable. And most studies say a 1 in 100 risk, so that 1% risk, is not considered a tolerable risk for most people. Most people would consider a 1 in 1,000 risk more realistic as to what they'll put up with. But 1 in 100 is generally considered too high a risk for most people to think that that's a reasonable thing. So if you think about kind of a few drinks a week or 1 drink per day, that's that risk. That's around about the 1% kind of lifetime risk. The type of alcohol is like, it doesn't matter. That's the bottom line. It really doesn't matter what form you're taking, beer, wine, shots, whatever. It really doesn't matter. The alcohol industry does spend a lot of effort to make sure that people think one is better than the other. So red wine's good for you. Okay, we can debate that actually, but even if it is potentially good for your heart, which there's not a lot of evidence that says it is, it's for sure bad for cancer. So, choose which risk you're willing to put up with. So yeah, the type of alcohol doesn't matter. It's the quantity, right? The last part on there, and this is, I think, a little more relevant perhaps to the younger generation. I'm generalizing that very much. But, I only drink on the weekend. I go out on a Saturday night and, we're going to the bar or something. So there is biologically a difference between 1 drink a day, a kind of low level chronic intake, and like a heavy alcohol intake, like binge drinking on the weekend or something. The pathways of damage through the system are different because our bodies can deal with things in a different way, depending on just the quantity, honestly. So the evidence, like the evidence for breast cancer is not huge that one is better or worse than the other. But biologically, it is a different thing. Okay, so before I get to my breast cancer specific pathways, I'm just going to go back to high school and undergrad kind of chemistry class. So how would I say it? So I think most of us did, some form of chemistry lab, at some point. And you talk about solvents, right? Even my kid is talking about solvents in junior high now. So, you have water and sugar and you get soda, right? And it's solubilizing, a crazy amount of sugar into Coca-Cola or whatever it is, right? Whereas a lot of things that actually don't dissolve very well in water do dissolve really well into alcohol, right? So if you remember kind of those chemistry experiments back when I was younger anyways, alcohol would sometimes be the solvent of choice to dissolve things because it dissolves things very well. So part of the thing, and this is not a breast cancer part, this is more just as a practicality in terms of, say, oral cancer, esophageal cancer, or just generally things that alcohol can do. Yeah, alcohol dissolves things really nicely. So if you're having a burger and a beer, and the burger has some charred meat, like it's a smash burger or something, and it's got that crispy kind of char on it because it tastes good. Well, that's carcinogens, right? That kind of crispy meat. You're then taking a solvent with your beer, and then allowing that to get into your system much more effectively. So, that would be one example. Another example, which is very, very well established, is smoking. So smoking, everybody knows, right? There's like 100 different things in a cigarette. And if you're having, a cigarette and, I don't know, a shot or whatever, you're at the bar and, or I guess, sorry, people can't smoke in bars anymore. But anyways, take a scenario, somebody's smoking, they're having a drink. You're essentially increasing the absorption of all of those toxins through your digestive system because the alcohol is a very effective solvent to get that stuff into your system where it might not have gotten in as well. So that's not so relevant for breast cancer, but I did see some guys on this talk, so I'm throwing some stuff in there. So that's more relevant for head and neck cancer and esophageal cancer and kind of digestive cancers. But yeah, I'll spin it back over to breast cancer here. So there's many mechanisms where alcohol can increase your risk of breast cancer. Some of them are directly causative. Most of them are kind of indirect. And I guess that's part of the thing about kind of that conceptual part of risk again, that if you say, oh, look, I'm a smoker and I'm going to get lung disease, like COPD or lung cancer, like people very easily can wrap their head around that to say, oh, I'm breathing in stuff, it's damaging my lungs. Like that's not a hard sell, right? People can get that really quickly. Whereas with alcohol, okay, I have alcohol and I might get liver disease. Oh, that only applies to the heavy drinkers. That's not me. But the low level stuff is the stuff that people don't really think about that much, including me, right? Like, I mean, these low level kind of things that are happening in our system, they're just not stuff that registers, okay? So we'll go through a few of them. I'm just watching my time. Okay, so one of the big ones is acetaldehyde. I don't know if I'm even saying that right, acetaldehyde. But the related chemical, which I looked up because I was just trying to kind of figure stuff out, everybody's heard of formaldehyde. So formaldehyde, I think most people know, is it's used in like embalming bodies. Like it's a pretty toxic chemical. It does a tremendous amount of damage to people. Like I don't know why you'd ever be exposed to formaldehyde, but it's industrial uses or something. But within our bodies, alcohol is not useful. Like when we take in alcohol, and I think people know this, your body actually can pretty effectively turn alcohol into energy, right? So that's why, when you're kind of thinking about, a beer or a glass of wine, like basically you're having the equivalent of like a candy bar. Like it's actually a pretty big sugar load into your system because your body can process the alcohol and turn it into energy. So, if it's a way to deal with this substance, and there's a very defined pathway through our livers mostly. But the problem is that there's kind of limitations of these enzyme pathways of just how much it can process. So in between alcohol and kind of a usable energy form is acetaldehyde. And that chemical by itself damages DNA. Like it's just straight out destructive for DNA. So, some of it comes down to metabolism. Like some people are very good at metabolizing alcohol, some people are not. This is also one of the things that goes back to that binge drinking versus chronic. Whereas, if you're just kind of having a low level alcohol exposure, your body can actually upregulate enzymes and deal with things reasonably efficiently, not perfectly, but reasonably. Whereas if you're binge drinking, you're just overloading the system, right? So things start to stop up and back up, and acetaldehyde is kind of more prevalent in those kind of scenarios. So it's different risk depending what you're doing. This was talked about a little bit, I think, just in the last talk too, about estrogen levels. Actually, I was very informed about that. So this is also kind of a back end way of how is alcohol causing breast cancer. And by far, it's estrogen receptor positive breast cancers. Okay, so I've had people tell me this. Oh, that's the good breast cancer. I'm going to be okay. So I'm going to still have my drinks. Like, fair enough, right? If you want to kind of go through that logic. But the scenario, again, it's not a direct effect. Alcohol isn't causing the breast cancer directly. But on the back end of estrogen degradation in your system, it's actually a competing mechanism for how alcohol is trying to degrade as well. So you're kind of stopping estrogen from degrading properly, which therefore results in higher circulating estrogen levels. And then over time, so once, not like a year or 2 years or something, but over time, higher estrogen and then estrogen receptors, there's breast cell proliferation, and then that can cause to increase mutations and then potentially breast cancer. The aromatase enzyme as well, that was a little bit related to the previous talk about body weight too. So there's a few things about that. So by itself, alcohol can increase aromatase enzyme levels, but also, I mean, once again, alcohol is energy. People who drink, it might be empty calories, they might be kind of heavier, and aromatase is present in fat cells. So it's kind of another back end way for that to be there. And aromatase is what can produce estrogen in postmenopausal women more. There was a really, really ridiculous kind of biochemistry image. I debated whether to put it into this, but I absolutely hated those when I would go to talks. It's like 100 different molecular pathways about how this happens. I didn't understand 99% of it, so I didn't put it up here. But if you're interested to look it up, you can. That basically at that same kind of pathway with this one, where alcohol is turning into sugar, the intermediary step is acetaldehyde, but part of that is reactive oxygen species come off at 2 steps along the way. So reactive oxygen species are the things that basically straight damage DNA, right? So oxidative damage it's a direct chemical effect. Yeah, DNA is directly damaged. Our bodies actually spend a tremendous amount of energy to prevent this from happening. And I mean, the whole thing about having antioxidants is exactly to prevent this from happening. So if you're out, having your green tea and broccoli or whatever, having super healthy diet, it then doesn't make a whole lot of sense to start putting in a bunch of alcohol to create extra oxidative damage. It just doesn't quite make sense. This was a little bit in the last talk too. It's relatively smaller for alcohol, but if anybody kind of goes to Emerge, I don't know where people work who are on this, but one of the things about kind of heavy drinkers when they come into the hospital is they usually end up getting some vitamin supplementation because they are generally vitamin deficient. So alcohol decreases the absorption of vitamin B9, which is folate. Yeah, I mean, the part where I kind of could recognize that the best was like in prenatal vitamins, the reason you have to take the reason you're supposed to take prenatal vitamins is folic acid is kind of one of the forms of folate. It's, I don't remember which one is the natural form and one is the chemical form, but anyways, it's the same kind of idea. But it helps the baby's neural tube system develop, which is kind of the precursor to their brain. So yeah, like basically it's part of just normal growth and development and repair. And in adult systems, it's basically part of the mechanism of how our body repairs DNA. So if you don't have enough of it, and then on the front end, you're kind of damaging it, it's just these cumulative kind of effects over time. This one's a little more vague, but I think perhaps relevant, again, if anybody's doing mammogram screening or, yeah, I mean, just generally, I suppose, but it goes back to kind of cell proliferation. So breast density by itself seems to be a risk factor for breast cancer. It's not a great kind of link, but it does seem to be there. But the other part is that I think most people probably know this, like higher density breasts actually make mammograms less sensitive. So it's kind of another, not causative kind of thing, but just like, oh, this is, it's possibly going to be worse than it otherwise could have been, right? Like maybe you were going to get breast cancer 10 years from now and your breasts weren't as dense, but because you were drinking, it kind of moved up the system by 10 years. And there's just a lot of variables that go into it. Okay, so I don't see the crowd in any way here, so it's hard to kind of read the room, but a lot of the talk in the Cancer Center, and I think in the news as well, is younger people are getting cancer. Like, I think most people in healthcare can kind of see that happening. I personally see it. The system sees it. Like DRCC sees it. The world sees it. It's being studied. And it's usually not the estrogen receptor positive breast cancers. It could be HER2 positive, it could be ER negative, could be triple negative. Like, there's all sorts of things about breast cancer where the younger people who are getting it, it tends to be just a worse, more aggressive breast cancer. So that also applies to colon cancer as kind of the other big one. We're seeing a lot of young people getting colon cancer. There's just relatively a lot of research going into it within the last couple of years, like kind of post-COVID. But the thing is, we don't understand very well how this is happening. So like everything that I talk about here, take it with a big grain of salt. But the UK had a good study that came out a year ago now, and that was more for colon cancer, but it was also, just kind of population level. And they were saying that ultra processed foods seems to be part of it. Low calcium levels, low calcium intake seems to be part of it. And alcohol intake seems to be part of it. So those three things were the things that they could kind of pick out in terms of kind of environmental changes over time, where younger people seem to be getting cancer. So some of it may be genetic, right? Like, we are increasingly recognizing there are some underlying, genetic abnormalities where people can get breast cancer or colon cancer. But you can't really think that the genetics of it would change within 10 years, right? Like, it doesn't really make sense to say, oh, from 2000 to 2020, the world's genetics has changed so dramatically. Like, that doesn't make sense. So there may be a factor in terms of genetics, but it's not realistically the factor of what we're seeing. And I don't think it's one factor. I think there's actually probably many, many things that are going on. But alcohol did make the list of kind of potential reasons why younger people are getting cancer. The mechanism is not the estrogen pathway, as best as we can tell. But there seems to be other things about how alcohol can affect breast tissue. And it's not clear. Like, that's really the answer. We don't understand it. So I put up just a few slides here. Or a few studies. One is, just in terms of having a cancer, alcohol intake can make that cancer worse. The corollary I'd use for that is better studied, I would say, is that when people who have lung cancer, people who are still smoking when they have lung cancer actually do worse than people who had already stopped smoking. So there's something about it where it's just worse if that is there. This one's a big stretch, but there does actually seem to be some pathway for this. So it's animal studies, but this even goes back a few decades. So it seems to be real. And I'm not a lab scientist, so don't hold too much of what I'm going to say about this. But apparently, I didn't really know this, but inside breast cells, like inside breast tissue, you can actually metabolize alcohol a little bit. So the acetaldehyde pathway is actually present in rats in their breast tissue. So as a mammal, if it's in them, it's potentially in us. But that whole kind of more direct pathway of damage of circulating alcohol gets to breast tissue And then there's direct damage in the breast tissue from acetaldehyde or reactive oxygen species. That may be part of it about how younger people are getting cancer. Like we really don't know, but it's basically speculation at this point, but it's a potential pathway. Okay, so it was what, 2022 or maybe 23. I don't remember. It was right around the end of the year. So Canada revised their consumption guidelines, and it made international news of, this was a drastic change, right? Of 2 drinks a day for men, 1 drink a day for women, and you're fine. Right? That was the standard guideline for my whole life anyways. And interestingly enough, if you still go to Health Canada, the official government website, at least as of a couple of weeks ago, it still says that. They still haven't actually modified to the new guidelines because, I'll give you a little hint, the alcohol industry is pushing back hard. So the new guidelines are 2 drinks or less per week. Okay, it doesn't matter if you're male or female. The risks are different for men than they are for women, but it's 2 drinks or less per week. Keeps you within that very low risk category. There's international guidelines, WHO, even the Surgeon General. That's one of my later things. So the Surgeon General down in the States had a whole large document about this that came out in 2024, I think. But I mean, once again, the whole thing is like, we don't need people to stop drinking, right? Like with smoking, it's different. The next talk I'll get into it. Like smoking does a tremendous amount of damage to the body. Alcohol does as well, but we're also kind of built to handle little bits of toxins and stuff, right? If you have a bit of a blueberry that has some fungus on it, you're not going to die. Your body will deal with that, right? So, low level consumption is arguably safe. Once again, the actual answer is 0 is the best answer. But I don't hassle people about it. Like just clinically, like if I see somebody who has a glass of wine or whatever, a couple of drinks a week, I don't make a big deal about it at all. But if it's like every day, okay, that's a conversation we need to have, right? Especially if they're like, oh, I have 2 a day, or I have 2 a day and I have an extra on the weekend. I hear that pretty frequently, actually, because those are the people who think they're within guideline, right? 1 drink a day is within guideline. I'm good. Yeah, so this was the Surgeon General slide. So I put this on the left. It's kind of a good summary slide of just kind of the mechanisms. Yeah, like basically there's multiple different ways. It's like the biology, the pathways. This is not like new science that people are coming up with. This has been around for a long time. And I mean, the general messaging is less is better, right? It doesn't need to be 0, right? But less is better. If you're having 2 drinks a day, try and get down to 1. If you're having 1 drink a day, maybe try and have some off days. Give your body a break. So, it's better for your system. It's probably better for your wallet nowadays too. But the messaging for us is generally less is better. Okay, not 0. Nobody really reacts well to the 0 messaging. This is a Canadian website. There used to be a Good American site. They got rid of it now. But this is from the BC group. So it's called noalcohol.ca, KNOW. And yeah, I mean, it's just kind of a calculator of what could you change about your lifestyle in terms of risks, in terms of finances even. It's part of the, just a calculator, how many calories, like empty calories are in your diet. It just runs through a few things in a pretty straightforward way of how many drinks a day. If I change to this many drinks a day, how would it change my wallet. And then the last part here is just kind of the basics. I really don't think this should be news to anybody, but actually we're all really bad at this, like myself included. Because if people can get this part down, they're doing like almost all of it. The extra little bits are great, but if you're missing out on any of these parts, you don't have to worry about the details. You just need to worry on the basics. So the basics are unchanged in almost all of human history, really. Like if you think about your grandparents or your great grandparents or whoever, like most of this stuff applies. Okay. So should you exercise? Absolutely. Anybody who thinks exercise is a bad idea, I have no idea what they've been taught. But realistically, for kind of a normal human, and I'm saying this as the Olympics are going on, it's not possible to overtrain your body if you're a normal human being. If you're an elite athlete, okay, sure, maybe you might overtrain, but for any regular person, you should probably be exercising more than you are because your body will appreciate it. Your heart, your lungs, your brain, cancer risk, everything. So exercise, absolutely. We just had an excellent talk about nutrition, so I'm not going to belabor this, but yes, obviously eat your vegetables. They're very, very good for you. Sleeping, I think, is under-recognized as just chronically bad if you're not sleeping well. So it goes to stress and stress relief and repair and all sorts of mechanisms behind it. But if you can't get a good night's sleep, it doesn't matter if you've got a perfect, exercise regimen. Like there's no point having a 24-hour gym and going to the gym at 1 o'clock in the morning if you then aren't sleeping to allow your body to repair. Like it just doesn't work that way. So getting a good night's sleep helps everything. Mental health, physical health, everything. This is an OBSP talk. So not just for OBSP, but I've put this in previous talks as well. Screening is very important, right? Whether it's fit testing, mammography, whatever, high-risk lung cancer screening. If you're eligible for screening, it is a very, very good idea. Okay. This goes back to what I was just saying about alcohol. It doesn't need to be a 0, right? Like a low-level intake, it's probably okay. Once again, I could debate with people. I do debate it with people as to whether it's a good idea. But, if you have a drink here or there at a wedding or whatever, like it's fine. It's not going to damage you. But whether it's binge drinking or chronic kind of low-level intake, that is for sure increasing your risk of cancer. There's no debate about that. And then the next talk, so this is a good segue, don't smoke. Smoking is really, really bad for the human body. So I think that's my last slide.
Wonderful. Thank you very much, Dr. Iqbal. That was quite a lot of information, incredible information on alcohol and what it does to our body. I will certainly be rethinking that extra glass of wine I'm going to have tonight. We do have one question, but I've got a feeling it's from Kelsey. And our next speaker is actually talking about smoking cessation, that sort of thing. So I think we might leave it for that. It's on vaping. Is that something you wanted to address, Dr. Iqbal? Or would you prefer it to go to the next speaker?
It's probably more appropriate to the next speaker because they probably know the evidence a lot better than I do.
Okay.
Yeah.
Okay. Well, do we have any more questions at the moment? No, we don't. Thank you.
Sorry, there is another question in the chat there. So, would alcohol also increase other hormonal cancers such as ovarian and prostate?
Yeah, I don't think.
That is a good question, and I don't know the answer to that. And I don't think we would ever know the answer for ovarian cancer, particularly because it's just so infrequent, like as a diagnosis, that to be able to pin down population level stuff to that, I don't know that we could ever kind of get a study to confirm that one way or the other. But I guess in terms of just kind of the biology behind it, it's probably not helping. Like I guess that's kind of the way I would say that. Prostate cancer is different. Prostate cancer is so that's more about androgens, right? That's testosterone. Um, I'm not aware that alcohol increases the risk of prostate cancer. I've never really seen that one read as far as like kind of the male side of what does alcohol do. There's plenty of evidence actually for colon cancer, head and neck cancers, esophageal cancers. Like guys can definitely get cancer from alcohol intake, but prostate cancer, I've never really seen that one as a link.
Perfect. And there is one more question that came directly to me. Has there been any discussion or emerging evidence around lowering the screening start age from 40 to 30, particularly for certain risk groups?
I think the way it stands now, Sarah, you probably know this better than me. Like you can actually ask for a mammogram at any age, right? Like you know the kind of letter screening program starts at it used to be age 50, then they're lowering it to 40. But if you think you need a mammogram, you can ask for a mammogram at any point, and you should be able to get one. So if somebody has like a family history or a specific risk factor that they're worried about, I'm pretty sure you can just ask for a mammogram and you can get one.
Yeah, so you can definitely ask your primary care provider for that. Organized screening right now for breast cancer starts at 40. And as a regional cancer program, we are not aware of guidelines changing lower. There is the high risk breast screening program, which starts at 30. There is a eligibility criteria for that. So if you'd like to learn more about that, you can go to checkforbreastcancer.ca. That will take you to our website. We have that on our slides at the end of the day as well. But organized cancer screening guidelines, we have not been made aware of changes, but like Dr. Iqbal says, you can speak to your primary care provider if you have concerns and feel that it's appropriate for you to request breast imaging.
Hey, are there any other questions? Anybody seeing another question? I don't think so. Dr. Iqbal, thank you so very much for your talk. That was great. Have yourself a good rest of the weekend.
Thanks.
Okay, so at this time, I think we're going to take a short break. Can we ask everybody to be back on screen for 10:30? See you then. Okay, welcome back everybody from your break. I hope you all had a chance to stand up, shake off some less energy, and get a coffee. Our next speakers are Huda Shah and Matthew George. Huda and Matthew are from the Ontario Health Smoking Cessation Program team in the primary and community-based care portfolio. Huda is a senior research associate epidemiologist with over a decade of experience in chronic disease prevention, beginning with one-on-one patient care and community engagement. She is currently pursuing a PhD in health services research at the University of Toronto's Institute of Health Policy, Management and Evaluation. Matthew is the lead for smoking cessation through Ontario Health, and during his time working in roles in the cancer system, he has experience working in program evaluation, program implementation, and as a quiet coach in a regional cancer center. In his current role, he leads initiatives to ensure every patient receiving ambulatory cancer care has access to cessation support and can get the most out of their treatments. Please welcome Huda and Matthew.
Okay, hi, good morning, everyone. Can everyone see the slides and hear me okay?
Yeah, looks great, Huda.
Perfect. Thank you so much for that introduction. My name is Huda Shah. I'm one of the epidemiologists at Ontario Health, and I'm joined today by my wonderful colleague, Matt George, who is the lead of smoking cessation programming at Ontario Health. And today's talk will really be about smoking tobacco and breast cancer. So some of the latest evidence on that. And then also Matt will go over some of the latest programs at Ontario Health, and then also talk about some of the cessation resources that you have available provincially that you can provide to providers and patients alike. So first, I actually want to go over some of the recent evidence on smoking tobacco and breast cancer. And when it comes to epidemiology, in terms of the pyramid of the hierarchy of evidence, what some of the gold standard evidence really comes from is what's known as these meta-analyses and systematic review studies. So what they do is they collate information from single studies. So we try to look at some of that evidence because it tries to show generally what the latest evidence is. And I looked at global evidence. So looking at things outside of just Canada and America, looking at Italy, China, South Korea, because there's data all over the world. And from 13 different meta-analyses and systematic reviews, we did find a lot of data in terms of associations. So I do want to give a bit of a caveat in that a lot of the studies that are used in these meta-analyses and systematic reviews are what's known as cross-sectional. So they're conducted at one point in time. And also some of them have data from retrospective cohort studies. So meaning that the outcome of breast cancer had already taken place. And then it's hard to go back in time and try to understand exactly what had caused the outcomes in those studies. So giving that caveat that these studies, we do still need stronger evidence in terms of causality, but again, it's hard to do that with cancer research. So just kind of presenting that as a bit of a caveat in terms of why my language will be a little bit muted. But all of these different studies, the 13 meta-analyses and systematic reviews, do suggest that there's an increased risk in developing breast cancer in the population that smokes versus those who don't smoke. And this risk ranges between 6 to 15%. I know 6% doesn't seem like much, but at a population level, that would impact a lot of people. So these are population level studies. And again, it's already very hard to show associations on a population level, but there has been increasing research that does find an association between the two. There was also data on secondhand smoke. So this is smoke that you're exposed to in public environments. And that also shows that there's a higher risk of developing breast cancer in those who are exposed to secondhand smoking. And we found higher associations, so 17 to 24% higher risk if you're exposed to secondhand smoking in terms of developing breast cancer. So we can see that the evidence is really pointing towards that actively smoking and secondhand smoke both may increase the risk of breast cancer in women. And there does seem to be a bit of a dose response relationship from these studies. So, what that really means is that the intensity of smoking and the length of smoking really determines. The level of risk for breast cancer. So, for example, how heavy of a smoker you are, how many cigarettes you're smoking is going to matter more in terms of breast cancer outcomes. How many years you've been smoking is going to also impact the level of risk you have in developing breast cancer. There was one study that actually looked at the age of initiation. So it was looking at if you start smoking at age 14, does it make a difference than if you start smoking at age 21? And it seems that that wasn't really that important. It's really about the intensity of smoking and so the number of cigarettes that you're smoking per day, and then also how many years you've been smoking. Some of the studies were also looking at subgroup analyses, and we know that hormones have a huge impact on health outcomes. So there is evidence to suggest that there's higher risk for premenopausal women as compared to postmenopausal women. And two of the meta-analyses that were coming out of China also showed a higher risk in Chinese women, so in Asian women. So on a population level, there's something to consider in terms of some of the subgroups. So what happens in terms of the population that has developed breast cancer then? How does smoking impact that population? In one of the systematic reviews, we actually found that 6 out of 8 studies showed that there was a higher recurrence of breast cancer in those who continued to smoke after they had been diagnosed with breast cancer. And former smokers actually didn't show these findings. So there is an incentive to quit smoking if you've been diagnosed with breast cancer. Another 2 meta-analyses found that there's approximately a 30% higher risk of death from breast cancer in those who smoke compared to those who don't smoke. And again, these studies actually looked at former smokers, and they found that former smokers didn't have the same mortality risk that current smokers did. Those who currently smoked also experienced worse health outcomes. So they reported worse skin issues, problems with their heart, problems with lung function, also complications from treatment. So things like chemo if you're diagnosed with breast cancer. And then also, as I just mentioned, more likely to die from breast cancer if you continue to smoke as compared to those who quit smoking or have never smoked. So we know that smoking, if you continue smoking after you've been diagnosed with breast cancer, can worsen the reoccurrence of breast cancer. You're more likely to have breast cancer again. It can actually promote treatment complications. So treatments might not be as effective, and you're more likely to die from breast cancer if you continue to smoke. So how is smoking cessation linked to breast cancer then? There's a meta-analysis that actually found that smoking cessation shows that harm declines with longer cessation time. So the longer you quit smoking, the better your outcomes of not getting breast cancer. Another systematic review and meta-analysis actually showed that in people who still smoke, there was an approximately 30% higher probability, so these are hazard ratios, of developing breast cancer compared to those who never smoked. And then in those who were former smokers, so these are people that were smoking at a point but had quit smoking, there was just a 2% higher probability of developing breast cancer compared to non-smokers. So again, you can see that the data really supports there's a huge incentive to quit smoking after you have developed breast cancer if you are someone who is actively smoking. So we know that quitting smoking and making sure that we're not exposed to secondhand smoke in public environments can also help to reduce the risk of breast cancer. This also has implications in programming when we're developing smoking cessation programming. Maybe we want to consider earlier interventions because we know that the length of time in terms of how long the person has quit smoking matters. Maybe we want to make targeted interventions for premenopausal women because they tend to have a higher risk. maybe we want to focus on cancer survivors to prevent that reoccurrence from occurring, and then also focus on policies in our public environment. So the workplace, for example, the studies coming out of China were able to show that in the workplace, people were exposed to secondhand smoke, and we don't have that here in Canada. So maybe trying to promote policies that prevent individuals from getting exposed to secondhand smoke as well. So overall, the evidence really shows that smoking cessation improves outcomes in patients who are diagnosed with cancer. So the treatments are known to be more effective. If you quit smoking, you are more likely to live longer, your quality of life improves. We know that there's a decrease in side effects from treatments as well if you are no longer smoking when you are diagnosed with cancer. And then also, again, the decreased risk of the cancer reoccurring, the decreased risk of developing tumors as well. There is a lot of data and evidence in terms of just how cost effective it is to implement some of these smoking cessation programs to make sure that individuals who are smoking don't go on to develop cancer, or they don't go on to develop cancer again, so reoccurrence of cancer. And so for anyone who's working in management, for example, there's a lot of data on some of the return on investment and cost effectiveness of this. I have included all of the references that are cited in this talk, and I'm happy to share those as well for anyone who wants to dive in deeper. But for now, I'll hand it over to Matt to talk about the programming.
Great. Thank you, Huda, and good morning, everyone. For my portion of the presentation, I'll be sharing some information on programs led by Ontario Health that help to improve access to cessation supports. And then we'll finish off with some sharing of some available resources out there for you and for your patients. So we want to highlight these programs, and 3 of them here, that include tobacco cessation support for their respective priority populations. First, there's the Indigenous Tobacco Program, where the team works with First Nations, Inuit, Métis, and Urban Indigenous, as well as some non-Indigenous partners to address tobacco, vaping, and cannabis prevention. At Ontario Health, we have the Smoking Cessation Program, and our team oversees delivery of smoking cessation program within ambulatory cancer care. There's an evidence-based program delivered by regional cancer programs throughout 14 regional cancer centers to ensure patients have access to cessation supports they need and can get the most out of their cancer treatments. Then we also have the Ontario Lung Screening Program. Cessation programming is very similar to what we have in our ambulatory care centers, and there's a smoking cessation component to ensure all individuals interacting with the program have access to tobacco cessation supports. And I'll share some more details of those to come. First, the Indigenous Health Unit at Ontario Health includes tobacco-wise leads, and these individuals work with communities and organizations across the province. The leads are involved in some community engagement, program and resource development as well, and have expanded beyond tobacco cessation to work also in supporting chronic disease more broadly. Programming is co-created with communities and is definitely culturally relevant. And examples of some resources you can see here on the slide. There's many more available online and I believe to print as well. Moving next, we have an infographic here that depicts the basic framework at regional cancer programs and the ones that they adapt to deliver smoking cessation programs in their respective regional cancer centers. When new patients are diagnosed, they enter into ambulatory cancer care. They're then asked about their tobacco use status, advised on the benefits of quitting, and not just advise on the benefits of quitting, but advise on the benefits to their specific treatments and outcomes, and then referred onwards to comprehensive on-site or community-based smoking cessation services, depending on what's been adapted and connected with partners in their local centers. And just to give you a sense of numbers, you can see there on the right side, in the previous fiscal year, the program screened over 60% of new patients, a big part of entry into the system, into the program to ensure that people are getting effective smoking cessation supports or maintenance supports. And that accounts for over 46,000 patients. And in quarters since, the screening or tobacco ask rate has moved closer to 70%, an early and important entry into the program. Of those screened for tobacco, just so you get a sense as well, about 15% or about 7,000 individuals have been identified as using tobacco sometime in the last 6 months. And then of those individuals, close to 30% accept a referral to the more comprehensive cessation support services, often including behavioral supports and access to pharmacotherapy. Wanted to touch briefly on some of the contributions from Ontario Health to the smoking cessation program as we act as a centralized support. The program provides some annual funding for program delivery and also, the presence of a smoking cessation champion at each regional cancer center or in each regional cancer program. There's regular engagements with the regional smoking cessation champions, facilitation of some shared learning opportunities, different connections that are made so that counterparts can connect and share learnings with each other. Our team has a set of provider and patient-facing materials as well as some modules to support intervention delivery. And then we also have some sets of evidence summaries, some publications that we work on and share with other partners, and also produce regular performance reports to support delivery, performance management, and quality improvement. Lastly, I wanted to highlight the smoking cessation program offered in the Ontario Lung Screening Program. There is that smoking cessation component as part of the navigation through that program. On the left side, people who are eligible and accept screening are automatically scheduled for smoking cessation counseling sessions. And this is a conversation with a trained counselor. They're usually the screening navigator. And the intervention consists typically of behavioral counseling, a recommendation or a prescription for pharmacotherapy, and also connected to follow-up supports. In the middle, we mentioned that patients or individuals, who are eligible for the program but decline screening, they're offered a choice of hospital-based counseling or referral to Health 811, which offers over-the-phone support by a quick coach. Then on the far right, if an individual is not eligible for screening, they still are offered a referral to Health 811, and this is through that over-the-phone support by a quick coach. It is important to note that people can still be screened for lung cancer if they decline smoking cessation support as part of the OLSP. And then I also wanted to mention at a certain time, typically 6 and 12-month follow-up appointments, screening sites will receive an update on participant smoking status, and there's that additional opportunity to connect, reconnect, and provide additional supports where needed. So I'm going to turn next to smoking cessation services and resources. Wanted to mention these just as you're thinking about your own learning, potentially as a refresher, and also some places that you might want to look into and some resources you want to look into to support your patients. So first, I want to mention the smoking cessation support services that you can keep in mind for your patients. These are places that you can help refer your patients to for more comprehensive supports. There are certain pharmacies, likely in your regions, that have trained staff to provide programming, and that's typically to eligible patients or eligible individuals for Ontario Drug Benefit. I am hearing that those not eligible for ODB, oftentimes pharmacies will still provide care on that support service or will do so for a fee. There is no master list of which pharmacies do this, though certain clinics do have knowledge of the local pharmacies with the program, and sometimes we see retail pharmacies, they post online so you know which pharmacy might offer the smoking cessation support that you can come into live and meet with a pharmacist. Health 811 was mentioned earlier as part of the OLSB. There's also referrals through the cancer program that way as well. Health 811 can be reached directly by an individual, like dialing 811, or through a provider who can call on their behalf, or through the fax referral. So you might remember smoking cessation, smokers helpline fax referral. That's moved through telehealth fax referral, and then now on to Health 811 fax referral. We're looking to, not we personally, but Health 811 and the ministry are looking to update that to eventually have an online entry into that versus a fax referral type referral. This does have to come with consent, and what often happens is a navigator or this will be the first point of contact. There's some intake questions as well as some additional consent is provided, and then there's connected to follow up by a quick coach. The support is tailored over multiple sessions and can continue as much as needed. You may also have heard of STOP, the STOP program. So that's from CAMH, and that's the Smoking Treatment for Ontario Patients program. It's available through certain primary care clinics, Aboriginal health centers, Stop on the Net, as well as some regional cancer centers and other health centers. Through the program, patients can receive behavioral supports and access to pharmacotherapy upon enrollment, at minimum at 6 weeks of nicotine replacement therapy, and that is a mix of long and short acting, if that's chosen, patches and gums, all the way up to 26 weeks of replacement in some programs. Through the program, yes, the patients can connect and receive that that amount of nicotine replacement therapy. There might also be some supports that you can connect to with your local organizations. Now turning to online resources for providers. We have a set of resources for you here. This is amongst many others. These, though, are specific to what we know is available in Canada and many in Ontario. A key item I'd like you to pay attention to and likely seek out if you would, is the updated recommendations for tobacco cessation that was released by the Canadian Task Force on Preventative Health. This is focused mainly in primary care, but obviously has some importance and some overlap with many priority populations out there. I think it is a key reading for all providers. Plenty of resources offered by CAMH as well. One being a specific course on tobacco use intervention in cancer care settings, so you can look for that. Ontario Health, I mentioned earlier, we do have some modules available, one for patients, one for providers, to help support you in your support of intervention, provision of intervention for general smoking cessation and also in cancer care. Smokers Helpline has plenty of resources to support patients, and has a set of tools for you that you can access and print or lean on when supporting clients and patients. And the last one there is a toolkit from the Canadian Pharmacists Association. That includes a lot of information and approach for support delivery. This was built in and is leveraged for a lot of the different pharmacy programs we have in Canada. But there is a lot there with toolkits, guidelines out there worldwide. So you can continue to look for those over and beyond what you see here on the screen. Now, last, to touch on some online supports and online resources for patients. We want to mention plenty of resources available for your patients online and to print. Some of them are more self-directed. Some of them you can work through with your patients. So we do have a resource I want to call out specifically for this event. Central East Regional Cancer Program has been working to update an item that provides supports and services that are available by city within their region. So this includes information on programs beyond STOP and Health 811. They do mention where you can get those, but also programs that are that can be found in FHTs through public health units, as well as certain community health centers and other retail pharmacies in amongst certain cities within the region. CAMH hosts plenty of resources, so as mentioned, many for you and as providers, but has many for patients as well. Smokers Helpline maintains their self-driven online quit program. So you can guide patients to that. Talk Tobacco is associated with the Canadian Cancer Society and it offers culturally appropriate support for cessation amongst First Nation, Inuit, and Métis and urban Indigenous communities. And then mentioned earlier, Ontario Health, we have some modules, videos, evidence-based evidence products to help support patients. And then last on the list here, we have the item from Health Canada. Plenty of resources, and this item continues to evolve. There's many exercises and tools that can help individuals move through quit planning and maintenance. So just in summary, please consider these educational supports for yourself, for patients as part of a combined toolkit to support your patients and clients live tobacco-free. So coming to the end, we want to thank you for your attention today. If you do have questions on the Ontario Health Cancer Care, the program in cancer care, you can reach out to Huda and I through the Smoking Cessation at Ontario Health. We have the OBSP generic inbox there as well if you have dedicated questions there, or tobacco-wise as well. So thanks very much, and I'll move it back to Glenda.
That's great. Thank you so much, Matt and Huda. Such great information and resources available through the program. We do actually have a question that was posed to our last speaker, but we thought this would be more appropriate for you guys. Now, Matt, one of your slides mentioned the vaping and your health. The question is, do we have any information on vaping yet, comparing it to tobacco?
Okay, I will answer first. My knowledge of that isn't as strong as I'd like. I know it's a relative new area of research, and conclusive evidence might not be formed. Um, uh, I would say some of the evidence is starting to form more around nicotine and cancer progression, and so that might be an area to start. Hood, I'll turn it to you just in case you've came across some things in your evidence study.
Yeah, so I mean, in terms of breast cancer, I think that it's a relatively new area, just because, vaping, they're still trying to solidify that association between vaping and lung cancer. There is a Cochrane review that does show a positive association between the two. So, that's a bit more solidified than breast cancer per se. I think that in general, there is some evidence to suggest that vaping is associated with late stage breast cancer, if I'm remembering correctly. But I'm also happy to go back and check the literature to see what the latest evidence is. But overall, vaping is a relatively new area that the researchers are looking into. And again, as I mentioned, with these population level studies, it's very tough to show any kind of causality. So if anything, you would come away with some kind of, there seems to be a positive association between the two. And so far, it's more conclusive for lung cancer for sure.
Great, thank you very much, Huda. Are there any other questions from the audience? Not seeing anything. Okay, thank you both. Have yourselves a wonderful rest of the weekend.
Great. Thanks, everyone.
So our last speaker today is Dr. Rula Shaheen. Rula is the Regional Breast and Cancer Imaging Lead for the Central East Regional Cancer Program. She completed and ended her 10-year term as Chief of Radiology and the Medical Director at Peterborough Regional Health Centre. She was appointed the Provincial Clinical Lead for Mammography Quality Management Partnership, QMP, a joint program at Cancer Care Ontario and the College of Physicians and Surgeons from 2016 to 2019. She completed Global Executive MBA in Healthcare and Life Sciences from the University of Toronto and was the class of 2021, and is the founder of the Women's Imaging and Leadership Lab, The Will. Dr. Shaheen received her medical degree from the University of Jordan and completed her residency training in radiology at the University of Toronto. Dr. Shaheen is a fellowship-trained woman's imaging breast imager from Harvard Medical School. She is passionate about improving global access to high-quality care through innovative digital technology. Dr. Shaheen is a strong advocate for healthcare providers' wellness, career advancement, and mentorship, with a special interest in enablers of overarching diversity, equity, and inclusion practices. Please enjoy Dr. Shaheen's recorded talk.
I'm the Regional Breast Imaging Lead for the Central East region. Today, I'm going to talk to you about a different topic from the usual topics that I have in radiology, but it is very important for any healthcare provider to be aware of how to take care of themselves and others. So my topic today will be taking care of each other in healthcare. I don't claim I'm an expert, but I do work with experts. I learned from you guys, and it's very important to share our experiences. I'll start by a small, short self-reflection exercise to get us in the mood, and then we'll talk about the value of taking care of each other and end with some lessons learned actually from your input. It all starts with you. So taking care of yourself is the most important thing because you cannot give what you don't have. And let's start with the first part of the self-reflection exercise. Think of it when you were very stressed and overwhelmed at work. Wished you can get some help or even a break. Then think of the following questions. Did you consider asking for help at that time? Or maybe you were hesitant to ask for help. Probably you were worried about getting rejection. Were you worried you will be judged? And then you decided not to ask for the help because probably you thought it's inappropriate? Okay, take a pause and think of another situation. Think of a time you observed a colleague in a stressful situation and visible emotional distress. And think again of the following questions. How did you feel about your colleague's situation? What did your other colleagues do? Did you consider offering help, or maybe you waited for others to help? Or probably you thought maybe it's better to be asked for help before you offer it. Now, for both narratives, try to think of what you could have done differently to get a better outcome, in your opinion. So that's for you to reflect on something that happened during your work. I'm sure we all have been through both situations and probably wished we can do better, or probably we're very proud of ourselves and we did better, and we probably should share that with each other. So reflective practice in healthcare is very important, particularly when things go wrong. We do it all the time. You know, the root cause analysis sessions, the quality QA sessions that we do at the hospitals. But I would argue it should not be just limited to reflecting when things go wrong. Like, you know, when you have a post-operative complication, or if a cancer is missed, or if a patient is complaining. We need to reflect, obviously, of course, if we failed to help our colleagues when we were able. And probably that help that we couldn't give could have made a difference, particularly in patient, and could have improved patient outcome. So reflective practice is very important, and it will give us meaningful and rewarding career in healthcare, and obviously it will improve our skills. Now, reflective practice in healthcare when things go well, which is, I would argue again, it's as equally important. It's great and as useful. It's very rewarding, builds confidence and positive culture, and also it's better for learning. As you know, the peer learning now, they have a major focus on good catches. And I would like to propose a tool called Rosebud Thorn Framework. It's transformative and reflective tool. It can work at personal level and at team level, and consider trying periodically. The way it works, when you get in a meeting, or if you want to take, let's say, 5 minutes at the end of the day to reflect on how did your day go, or if you're meeting with your team on weekly or monthly basis, this is how it goes. Like the rose would be a positive highlight, something that happened really, you did well, or happened in the department that really was a positive thing. And the bud is identifying an area to improve on. And the thorn is something that is not so positive highlight in your day, in the week of your work, or in the department meeting monthly. So it's important to reflect and acknowledge this and figure out a way to get through this. The value of taking care of each other, it's obviously there's a huge value. I don't even need to go through that, but like it's just important to remind everyone it's a shared responsibility, because it does create a safe and healthy work environment, and it does subsequently improve patient care and patient outcome. And it's simply the right thing to do. So really, there are so many ways and forms and shapes, big and small, to take care of each other. And honestly, in healthcare, given how stressful is our job, how traumatic it can be due to different reasons, and because of the time limitation on this talk, I thought it's best not just to collect evidence base and read paper and bring it to you, because there are so many ways across cultures, across severity of the situation. I thought it's best to reach out and ask for the help of my colleagues and friends in healthcare and get their experiences. And through their eyes and through their experiences, we can all learn or even share, I would say, probably because probably that was you too. So I'll start with Kirsten. Kirsten is our regional vice president for the Central East region. And she talked about her experience during vulnerable times. We know it's very hard to lose a loved one, whether it's a parent, a son, a sibling. It's very, very, very tough time, vulnerable time. So she says, when my father passed away, colleagues across my teams reached out with genuine care. They sent messages, flowers, and one program even came together to give me a gift card so I could plant a tree in his memory. It wasn't the gesture itself, but the feeling of being seen and supported by colleagues at every level during a deeply human moment. So it's very, very important to reach out to each other when we are at these very, very hard and vulnerable times. Also, another wonderful example that I really like that goes across the cultures and exchanging kindness across the cultures. She said, when I was new to my executive position, I came down with a very difficult cold that led to pneumonia. The Indigenous patient navigator knew that I wasn't feeling well, offered a smudge, and provided a self-care kit after I was no longer infectious, of course. It was an incredibly thoughtful act that not only deepened my understanding of Indigenous ways of knowing, but made me feel truly cared for when I needed it the most. So I love this example because we come from different backgrounds, different cultures, and sometimes we're hesitant. In some cultures, we think we're crossing the line or maybe it's inappropriate. I feel like it's always okay to ask, can I offer you this? Is this okay? And once you feel like the person is willing to take the exchange of experiences and cultured experiences, it would be wonderful. Dr. Tina Oliphant is a wonderful colleague of mine. She's a breast imager. She's also the co-founder and committee member of the Black Physicians of Canada and Mentorship Program. She raises a great point about the importance of mentorship, sponsorship, and support. She mentions the following. She said, earlier in my residency, 2 attending radiologists took a significant interest in mentoring and sponsoring me. One clinically and another in research. At a time when I struggled with imposter syndrome, which a lot of women suffer with that, and the pressure of balancing work and home life, these 2 women who were also mothers chose to include me in their projects. Their support helped me overcome my doubts and develop professional confidence, which directly inspired my current commitment to mentorship. So mentorship is very important, especially if it's the perfect match. And it would be lovely if you are offering, like, it's not, what I like about this example is the fact that the mentor offered the mentee. Most of the time, we reach out for our mentors, which is nothing wrong in that. If anything, I would argue the mentees should reach out to their mentors and choose their mentors. But I think this is a great way of taking care of each other. Also, Tina gave another example about a vulnerable situation when she experienced that a family member abroad had an emergency, and how colleagues supported her with messages, with being flexible at work. So it's amazing. Christina Murphy, the Director of Risk Patient Relations at PRHC. She deals with a lot of physicians, families, and complaints. I don't know how she can do it. It's wonderful. But one of the things that she shared with us is that a thoughtful note from a colleague made a huge difference. So she says the following: after feeling defeated on a difficult day that I spent listening to many angry patients, families, and staff, a colleague put a sticky note on my computer screen that said the following: you cannot fix everything. Listening is often enough. Grateful for you, keep going. And Christina was very grateful for that. Also, she shared a similar experience like before when her mom died, and she gave the date on December 21st, 2021. She really loved the fact that someone did a beautiful gesture and meaningful gesture, I would say, by a colleague who brought her a plant with a small red cardinal figure in it to represent her mom's spiritual presence. The other thing is, Christina reminded us that hospitals can also have kind gestures for physicians. Like, I think she referred to, we have snacks, including granola bars and fresh fruits in the doctor lounges, because they recognize how busy the physicians are. And basically, that was a very nice way of sharing how can we take care of each other. Dr. Yusra Al-Makadma, a family doctor at the medical center, reminding us that there is a human behind the physician. So she talked about the importance of the vent sessions and pitching in. So being a healthcare provider can be tough sometimes. My favorite examples of ways to take care of each other include honest check-ins, not just, hey, how are you? And, walking by, like really you go in and look in the eyes of your colleague and say, are you okay? How's it going? And maybe take the time to listen to your colleague, the vent sessions. And if there's need to help, they pitch in whenever it's possible. It's very important because after all, we're all people behind the profession. My colleague, Nikit Gandhi, Dr. Gandhi, a radiologist, breast imager as well. He's also the chief radiologist at Ross Memorial Hospital, touches on a very important point, which is whenever we make a mistake, we really need a gentle feedback. Whenever we're down and we're going through tough times in life, it's good to know that there's someone that we can go to. So he says the following: a colleague noticed I was not my usual self. He told me his door is always open if I want to talk. He really appreciated this gesture. He ended up going out with that colleague and talked about the stressors that he was facing. Also, a very important and brave thing to share with us is that after missing a finding on a CT scan, a colleague kindly pointed out the finding that she identified in a follow-up study. And rather than emailing me, she spoke to me face-to-face, which is, in my opinion, is the better option, in a very non-judgmental fashion, with reassurance that everyone makes mistakes. I think it's very, very important that we take care of each other by being kind to each other when we give feedback, especially if you feel that this feedback might affect the confidence. And it's hard sometimes to tell a colleague about their mistakes, but I think this colleague took a very important gesture by doing it face-to-face. It's very, very important. Thank you, Nikit, for sharing that. And now to Leslie Highway, the president and CEO of the PRHC Foundation. She talks about the importance of listening. She said, be a good listener, hold space for your colleagues. It's very important because you never know what they're going through. Also, she mentioned that in healthcare, there may be your colleagues, they may be experiencing burnout or emotional distress relating to their life. So your 5 minutes of listening and caring will mean the world to them. I can't agree anymore. She's also offering to say that hybrid workforce is very important. It helps maybe those with younger families. So also it's important to arrange time to meet in person to keep that kind of connection. So considering hybrid work environment is something very important and one way to take care of each other. Collaboration and teamwork by Samantha Feinberg, a breast imager radiologist at Lake Ridge Health. She's also the lead of OBSP in the Ontario Breast Screening Program. So Samantha talks about the importance and how one way to take care of each other is that recognizing how our work in breast imaging, which is very complex, is through teamwork. So one of the aspects, that's what Samantha is saying, one of the aspects I love about breast imaging is that it's truly team-based care. I could not do what I do without our team working together. It starts with clerical staff working with me to help schedule the patients appropriately, consulting with the technologist to make sure that the imaging is done to answer the clinical questions, and working up my colleagues' recommendations, because we don't only work up our own callbacks, we work in a group. In the breast section, we are all collaborating. Personally, I find having team support results in more positive, fun work environment and results in better care. Cannot agree more. Now to Dr. Dimitri Ranathanga, a breast imaging lead at PRHC. She talks about the importance of appreciation, recognition, and peer learning, another important points to stress during our daily work. So she says, blame comes easily, but appreciation isn't, but it does matter. Also, it's very important that you see your colleagues as challenges, no, but if they are opportunities to improve, opportunities to learn from each other, because none of us know everything, but each of us has something to offer. Learning from one another and offering help without judgment allows us to build a safe, supportive environment where asking for help feels comfortable. And that's like supplementing Dr. Nikit Gandhi's point. It's very important to feel safe, to share the good and the bad, the great catches and the misses without, through peer learning and without feeling threatened or judged. Compliment and acknowledgement. Lindsay Justinsky, she's our charge technologist and breast health navigator at PRHC. She deals with lots of patients, with lots of physicians from different backgrounds, multidisciplinary. And one of the things she shared, and she really has a great way of sharing it, is that we implemented a high five program that encourages staff to compliment or give kudos to their colleagues. It's very important. This is where if someone did something nice, we recognize it, we do hang it so that people can see it and people feel that their action or their kind gesture or their good deed was not noticed. Actually, it was. So this activity helps to promote a culture of teamwork and emphasizes how all team members are important to be able to continuously provide quality of care and day after day. Thank you, Lindsay. And now Jill Cummings, she is the charge mammography technologist from PRHC as well, talks about the importance of sharing knowledge and stories. As she says it really well, we are with our colleagues for a large portion of our lives. Very true. This means we become quite familiar with one another. Effort needs to be made for us to take care of one another and always work toward positive outcomes for patients and for ourselves. And with patient-centered care, the more support, the better. Therefore, from a professional standpoint, asking each other questions, sharing our knowledge and insights with one another so that we all succeed. It's a teamwork and it's a collegial gesture, the best collegial gesture. We also know that we perform better when we feel emotionally supported. Lastly, she's suggesting a friendly smile, a shared story, or a joke, hopefully a laugh is involved, asking about loved ones. It's very important. And most of this, we did allude to it, talking about genuine check-ins. So it's very, very important. Building trust and check-in again. I think check-in wins because we see it coming into, it's almost like a pattern. So Kristen is a sonographer at PRHC. She says, I work full-time surrounded by colleagues, 5 days a week. And one in particular, I know I can trust and value, someone I'm able to open up to about outside work topics, knowing that I have that person to check up on me at work with a smile or a chat in passing. Sending a simple message outside work is my favorite gesture that I perceive as taking care of each other. Thank you for sharing, Kristen. And last but not least, Dr. Jessica Leong, she's a radiologist and professor of breast imaging in Houston. She's also one of the past SBI presidents, Society of Breast Imaging in the States. She raises a very important point, that willingness to cover each other and provide enablers. A meaningful collegial gesture would be by helping with colleagues' work schedule so that she or he can potentially attend an event or pursue an activity that's otherwise is not possible. You know, like an important conference, an important workshop, something to advance the healthcare worker career. And sometimes without that coverage, it's not possible. And by covering each other, probably an early or late shift or even a weekend call, this would be very, very helpful. So with that, as you can see, there are so many ways and forms where we can take care of each other, because taking care of each other is the right thing to do. Taking care of each other comes in many forms and gestures, small and big, all have a huge positive impact. That's the most important thing. But remember, start with taking care of yourself, reflect, help, and ask for help. We're all human. Thank you for watching.
Thank you to Dr. Shaheen for that. That was a good bit of advice. I just want to say, because she's not online, if you have any questions, just put them in the chat box and we'll make sure that Dr. Shaheen gets them, and we will then send you the responses. So as you can see here, this is a survey and it is anonymous. This is our QR code. And we'd ask that you please complete it as your feedback is important to us for our future events. This will be put on the last slide as well. So don't feel like you have to just grab it right now.
So we're coming to the end of our agenda, but hoping you don't log off just yet. We have a few additional details we'd like to share with you. One is here around the Ontario Lung Screening Program. It was mentioned a few times throughout the day, and I think valuable information for your clients when they come in for screening, for any imaging, but also it may be applicable to yourselves, your families, friends, neighbors. The Central East Regional Cancer Program does have an Ontario Lung Screening Program. All referrals go to Lakeridge Health, where there's navigation and clerical support, and the actual screening occurs either at Lakeridge Health or most recently onboarded was Ross Memorial Hospital. And we are working to expand the screening sites for the low dose CTs throughout the region. But just to have a bit of detail around the program, it is for people who have smoked cigarettes for a total of 20 years or more and are between the ages of 55 and 80. That's the first step. This is considered a high risk program, so there's an eligibility component, but that will happen after the referral occurs. So to start the eligibility process, folks can either self-refer through the phone number that's on the screen, or a primary care provider, or a nurse practitioner or physician can send a referral into the Lakeridge Health Hub site. If you're curious and would like to know more information, you can go to our OLSP page on our regional website, and you can get there by going to checkforlungcancer.ca. We do want to share ways of staying connected with the Central East Regional Cancer Program. The email is on the screen there, and these slides will come out as well as part of the package next week. If you would like to know about all of the screening programs, including some prevention information around smoking cessation, around alcohol use, you can go to our website and you can get there quickly by going to checkforcancer.ca. To go directly to the OBSP and breast cancer screening page, you can go to checkforbreastcancer.ca. You'll see a bit of a theme here. So depending on the screening program you're interested in, you go to checkforthatcancer.ca. So check for breast cancer, check for lung cancer, check for cervical cancer, or check for colon cancer. And you will go directly to our page with more information around that screening program. We also have a very active social media pages where we share information around guideline changes, opportunities for screening through pop-up clinics, and also just friendly reminders about the importance of cancer screening. So you can follow us either on Instagram, and you can find us under Check for Cancer, or on Facebook. And those QR codes would take you directly to our page. And finally, we do have resources around OBSP and breast screening. We have recently completed and we have available a OBSP trifold. So it is high level information about the OBSP program. It includes information about the high risk screening program, what to expect during a screening appointment, how to prepare, as well as some potential next steps. So we do have that available. Just send us an email at the email address on the screen if you would like to request some copies of this trifold, and we can get some for you. And also, we are a Know Your Lemons certified breast education center. So what that means is we have access to additional resources through the Know Your Lemons site, which is a great way of speaking to patients in a non-threatening way about symptoms of breast cancer, the importance of knowing one's breast, the importance of screening. So again, if you would like some information about that, you can send an email to our website. So I think that's it for me. I believe I'm sending it back to you, Glenda, just to facilitate the final questions.
Absolutely. Thanks very much for all of that, Sarah. So we have finished just a little bit early. I just want to say one other thing here. Please check your emails Monday. for our slide presentations. And just to recap, the certificates will come in the next 2 weeks. And from the Central East Regional Cancer Screening Team, we thank you for joining us today and hope you enjoyed our presentations. Have a good rest of your weekend.
Hi, Marcy. I see your hands up. Is there a question we can help you with? Go ahead, Glenda.